जरा स्टॉप स्टे करके स्ट्रीम भी चेक करो। स्टॉप स्ट्रीम कर दो, टू कर दो।
पक्का?
हाँ
पक्का? कर दूं? कर दूं क्या? Hello everyone. Myself, Dr. Sanjay Khatri, your pediatric educator on Medway. Medway is the your door to dream. Yes, I am coming with pediatrics MCQ, top 100 questions that will definitely help you to crack your exam. Presently, our target is FMG 24. Okay, so here I am with top pediatrics questions, top 100 questions of pediatrics. Go with my experience. Okay, that will definitely help you to boost your preparation. These questions will help you in upcoming exam. So here we go. This is the first question. Try to interact in the class. First, try to give your answer in the comment box. Then I will explain you the logic and everything. Okay, a mentally retarded 5-year-old boy found to have macroorchidism and large prominent ear. Large prominent ear. Most likely, yes, these two are the classical point. Large testis, large ear. Yes, we are talking about Fragile X syndrome. Fragile X syndrome. Yes, these two are the classical find. Mentally retarded boy. Large testis, large ear. Only one possibility. This is Fragile X syndrome. And this commonly asked. 2 times in last 4-5 years, this question was there. Fragile X syndrome. It is second most commonest cause of mental retardation in boy. Which is the first? First is the Down syndrome. Second commonest. One more feature about Fragile X syndrome, it shows triple codon transmission. Triple codon transmission means anticipation phenomena. Severity of disease increase with successive generation. Disease is severe in grandfather, more severe in father, even more severe in son. Severity of disease increases with successive generation. It is triple codon transmission. Which triple codon? CGG. So yeah, these all are the MCQs of Fragile X syndrome. Mentally retarded boy, large testis, large ear. Fragile X syndrome. Second commonest cause of mental retardation in boy. Boy. Voice come aa rahi. Fragile X syndrome. Fragile X syndrome. It shows triple codon transmission CGG. Now, answer this question. You find this question invariably in all of the FMG exam. Yes, which biochemical marker used for antenatal screening of Down syndrome in first trimester? In first trimester, yes, we can diagnose Down syndrome antenatally. When mother is pregnant, before pregnancy, we can come to know this baby is Down syndrome. So we can give them the option they want to continue or they want to terminate. But how can antenatal screening of Down syndrome, antenatal screening of Down syndrome can be done by biochemical marker and by USG. What are the biochemical marker? Commonly by biochemical marker in second trimester. Generally, we do this test 16 to 18 week of pregnancy. So what are the biochemical marker by which antenatally we diagnose the Down syndrome? Alpha fetoprotein, estriol, HCG. These three collectively known as triple test. Triple test. Alpha beta protein decrease, estriol decrease, HCG increase. Triple test. The commonest question. triple test used in the screening of Down syndrome. But recently, fourth component added in this. They ask what is the fourth component to make it quadruple test. To make it quadruple test. The fourth component is inhibin A. FMG 2020. This was the question. All of the following used in the screening of Down syndrome. Screening of Down syndrome, except choice was inhibin B. It's not inhibin B, it's inhibin A. So what are the triple test component? Alpha fetoprotein, estriol, HCG. Alpha fetoprotein decrease, estriol decrease, HCG increase. What is the fourth component? Inhibin A. So this test we done in the second trimester. But if somebody asks first trimester, how can we diagnose antenatally Down syndrome during first trimester? These two are the tests. PAPPA, pregnancy associated placental protein A decrease, and beta HCG increase. Come to our question. Which of the following biochemical marker diagnose Down syndrome during first trimester? Yes, PPA and HCG. PAPPA decrease, pregnancy associated placental protein A decrease, and HCG increase. Yes, yes. So these are the things, biochemical marker of Down syndrome, antenatal screening of Down syndrome. I can bet this question will be there in your exam. Okay, because last 4 years, 3 times they ask about these marker. They can give which of the following is not correct. One increase, one decrease, one increase, one decrease. So you need to pick alpha fetoprotein decrease, estriol decrease, HCG increase, inhibin A increase. Second trimester, first trimester, PAPPA, pregnancy associated placental protein A decrease, and HCG increase. Shall I move? Antenatal screening of Down syndrome. These are the first trimester marker. These are the second trimester marker. Am I clear? Answer this question. Answer this question. 7-month-old child having loss of neck control. Exaggerated startle response. Here is the key. Exaggerated startle response. On examination, child is having macrocephaly, cherry red spot in eye. What is this? What is this? What is this? No, my friend Jelly, it's not C. It's classical Tay-Sachs disease. Tay-Sachs disease characterized by number 1, macrocephaly. Number 2, cherry red spot in eye. Number 3, neurodevelopmental regression. Written in the question, loss of neck control. The milestone which child achieved previously now regressing. Child is not able to hold the neck. Child is not able to make the eye contact. So what milestone child had achieved previously now start regressing. And number 4th is the classical which clinch the diagnosis. Exaggerated startle response. What is exaggerated startle response? If we make a noise in front of a neonate like this, if we clap, baby do like abduction, adduction, abduction, adduction. This is normal response. But if a slight noise, child do again and again like this, then we use the word exaggerated startle response, and it is the classical of Tay-Sachs disease. Note the point number 5. Tay-Sachs is the storage disease. All storage disease have organomegaly, hepatosplenomegaly, but Tay-Sachs no hepatosplenomegaly. And number 6th, no treatment. death in 4 to 5 years. So 6.6 means hexa. Tay-Sachs is due to deficiency of hexa aminodase A. So my friend, these are the classical point, classical history. You may get a one-word question. Exaggerated startle response is a feature of Tay-Sachs disease. Exaggerated startle response feature of Tay-Sachs disease. Which storage disease have no hepatosplenomegaly? Again, it's Tay-Sachs disease. If a clinical question, loss of neck control means neurodevelopmental regression, then macrocephaly, cherry spot in the eye. This question was there in last year FMGE exam, my friend. When I discussed the previous year paper, this was the question. A child with developmental regression, cherry red spot in eye, no hepatosplenomegaly. They mention no hepatosplenomegaly. Cherry red spot, no hepatosplenomegaly. It is Tay-Sachs disease. Tay-Sachs disease. They may ask you which enzyme deficiency is there in Tay-Sachs disease. Hexaminodase A. 6 point of Tay-Sachs. Hexaminodase A deficiency of Tay-Sachs disease. Fine. Try to answer this question. Try to answer this question. 4-year-old blue eye female manifest with malar flush. Mild mental retardation. Mild mental retardation. Subluxation of ocular lens. Marfanoid-like feature. Tall, thin, acronodactyly, long fingers. Most likely diagnosis. Marfanoid-like feature, it's Marfan syndrome. Hold. It's not Marfan because in Marfan, IQ is normal. But what given in our question? Mild mental retardation. Feature like Marfan. Feature like Marfan. But if child have low IQ, mild mental retardation, my friend, it's not Marfan. It's homocystinuria. Remember, simplest thing. Child with Marfan-like feature but mild mental retardation. It's not Marfan because in Marfan syndrome, IQ is normal. In Marfan syndrome, IQ is normal. So what is this? Homocystinuria. This is homocystinuria. Now, these are the feature. 4 classical feature homocystinuria. It is autosomal recessive disorder. Clear? Marfan-like feature. We know subluxation of lens, tall finger, thin child, high arched palate, Marfan-like feature. But there is mental retardation. There is mental retardation. So it's not Marfan. Marfan-like feature plus mental retardation, it is homocystinuria. Now, this is again a classical point. This is again a classical point. Prone for thromboembolic episode slash stroke. If you read in medicine, causes of stroke, metabolic, number 1 is homocystinuria. Surgery, deep vein thrombosis, causes, metabolic, number 1 is homocystinuria. Pediatrics, a child comes with unexplained stroke, unexplained hemiplegia. What is the probable cause? Metabolic cause, homocystinuria. And my friend, remember this thing, it is pyridoxine, B6 dependent condition. It is B6 dependent condition. So this is the classical question. Child, mild mental retardation, subluxation of lens, Marfanoid-like feature. What is this? It is homocystinuria. It is homocystinuria. Which syndrome have normal IQ? It's Marfan syndrome, which is having normal IQ. Now, can you find out? Watch this image for 15 seconds at least. First, read the question. Infant born with malformed forearm noted to develop severe hemorrhagic manifestation. Which of the following would be the most likely cause of bleeding problem? Hemorrhagic manifestation. So you must be thinking, it is vitamin K deficiency. No, jelly is right. It is thrombocytopenia. The question, malformed forearms. See the picture here. Normal radius should be there, which is absent. Radius is absent. If child born with absent radius, which blood test you want to do first? Which blood test you want to do first? Yes, WBC count, RBC count, neutrophil count, platelet count, because there is a known entity, Paar syndrome. Thrombocytopenia, absent radius syndrome. Baby born with absent radius, you need to check platelet count first. Are we dealing with Paar syndrome? Absent radius, platelet absent. It is Paar syndrome. Absent radius, platelet absent. It is Paar syndrome. Remember this diagram in your mind. Absent radius, platelet less, thrombocytopenia. Absent radius, thrombocytopenia. It is Paar syndrome. Child born with this X-ray, child born with malformed forearm, child born with absent radius, all these things you remember, having bleeding manifestation. Why? Absent radius, it is due to thrombocytopenia. Am I clear? So these all are the classical question. Fragile X syndrome, Down syndrome antenatal screening, Tay-Sachs disease, Homocystinuria, now Paar syndrome. What else you want? Okay, now answer this question. Try to answer this question. 10-year-old female child presented with short stature, webbing of neck, cubitus valgus. What is this? Short stature, webbing of neck, cubitus valgus. It is Turner syndrome. No. Habit. Read the question properly, completely. Her chromosomal study shows normal karyotype. What is the karyotype in Turner? 45X0. So with this history, normal karyotype. It can be anything, but it can't be Turner because Turner karyotype is not normal. So when feature suggestive of Turner syndrome, plus normal karyotype. Anybody in the comment box? What is the name of this syndrome? Feature of Turner, but normal karyotype. It is Noonan syndrome. It is Noonan syndrome. Feature of Turner plus normal karyotype. It is Noonan syndrome. Am I clear? So don't misguide with this question. All the features of Turner are there, but and they mention normal karyotype. Like previous question, all the feature of Marfan is there, but beginning they write mental retardation. So it can't be Marfan, Homocystinuria. All the feature of Turner, but karyotype normal. So it can't be Turner. It is Noonan syndrome. Now see. These are the feature of Turner syndrome. Watch this picture. Watch this picture for at least 15 seconds. So what you are interpreting? Webbing of neck, low hairline, arched palate, low set ear, coarctation of aorta, bicuspid aortic wall, horseshoe kidney, streaks ovary, cubitus valgus, broad, widely spaced nipple. These all are the feature of Turner syndrome. Turner syndrome. Now there are few very good MCQ on Turner syndrome. Turner syndrome. Most common organ affected in Turner syndrome. It's ovary. Ovary. Early menopause. Fatty streak ovary. The most common organ effect in Turner syndrome is ovary. Most common cardiac lesion in Turner syndrome. Coarctation of aorta. Coarctation of aorta if child is symptomatic. If asymptomatic, it is bicuspid aortic wall. So always consider whenever question come, most common cardiac defect in Turner syndrome, always write coarctation of aorta. Most common renal defect in Turner syndrome. Yes, anybody? Most common renal defect in Turner syndrome. Horse, shoe, kidney. These all are MCQ. Most common organ, ovary. Most common cardiac defect, coarctation of aorta. Most common renal defect, horseshoe kidney. These are the feature of Turner syndrome. Cubitus valgus, low hairline, webbed neck, coarctation of aorta, streak ovary, horseshoe kidney. Turner syndrome, and these are the MCQ. One more image based question in Turner syndrome. Here it is. Watch this picture carefully. Watch this picture. What you are interpreting? What you are interpreting in this picture? First, second, third, fourth, and fifth. What you are seeing? Short fourth metacarpal. Short fourth metacarpal. Short fourth metacarpal. See in our fingers. Fifth, fourth is always taller than fifth. Here, fifth and fourth is almost equal. You can interpret it. Fourth finger is short. Why it is short? Short fourth metacarpal. This is the classical feature present in Turner syndrome. Classical feature present in Turner syndrome. So yeah, Turner syndrome, FMG okay. But in NEET 2022, two question in a single exam from Turner syndrome. Single syndrome, single exam, two questions. A 10-year-old girl present with short stature, webbing of neck, cubitus valgus. What is the common USG finding in that girl? Fatty streaks ovary, commonest finding. Okay, and the one history base, short stature, webbing of neck, cubitus valgus. We are talking about which syndrome? It's Turner syndrome. So my friend, these Turner syndrome history based question, one word question. These are the one word question. Down syndrome, antenatal screening of marker for Down syndrome. These questions they will ask frequently, and we are here 100 Sawaal. So Sawaal Abki Baar. Okay, these are the most important question. You just brush them up, just revise with me. I will help you. I will help you. I remember all the 5-6 year questions. So I put basics and those questions with you, discuss here with you to give you the clear concept of most important question for your upcoming FMG exam. Answer this question. Answer this. Read this question first. 18-year male child presented with complaint of delayed onset of puberty. Examination, tall, underweight, child having large arm span, small testes. Now, this is Klinefelter syndrome. 47 XXY. One X is extra. these patients remain undiagnosed till they presented to pediatrician or endocrinologist with the complaint of delayed onset of puberty. Secondary sexual characters are not developing. Initially, there are few signs symptoms, so that individual not come into attention. Child is tall, thin, underweight, having large arm span and small testes. So they don't come in attention. But when they not attain the puberty, when they not able to attain the puberty, yes, there is a delayed puberty. In that sequence, when we investigate them, then they find this child is having Klinefelter syndrome 47XXY. 47XXY. Large test is the feature of Fragile X syndrome. Small test is the feature of Klinefelter syndrome. Now, they not come into attention in their early childhood. They come into attention when in early childhood, if they have antisocial behavior during school days. 10-year-old child reading in 4th standard, very aggressive, tod dunga, maar dunga, jala dunga, very aggressive. That aggressive behavior is inappropriate for his age. Then we suspect something is abnormal. How such aggressive a 10-year-old child? Some abnormality is there. Antisocial behavior in school days, tall, thin male child, large arm span, small testes, delayed puberty. Yes, we are dealing with, yes, Shahid, it is Klinefelter syndrome. Klinefelter syndrome. So you should remember down questions, so many. Turner, Klinefelter, now they are moving towards other syndrome in your exam because FNP exam, I am getting some very, very, very good questions. Yes, they increase their level since last two exam. They can ask some good question also, and this is one of them. Now, answer this question. If you remember till what I told you in the previous slides, if you remember, you can definitely answer this question. Yes. A 5-year-old child with developmental delay brought with frequent squinting, bilateral lens subluxation. Squinting, lens subluxation, developmental delay. Marfan-like feature, developmental delay. So what is this? Homocystinuria. I told you, homocystinuria. Now, after 4 years, he dies of massive stroke. I told you, patient of homocystinuria prone for thromboembolic episode, strokes. Autopsy revealed middle cerebral artery thrombosis or renal infarct. Clear? So we are dealing with a homocystinuria. Now listen. Disease course could have been modified by homocystinuria is a pyridoxine dependent condition. If you supplement B6 to that patient, disease course can be modified. Shahid, you got it? So correct answer it is pyridoxine dependent condition. Yes, I told you in the previous slide, previous question, homocystinuria, it is autosomal recessive. Marfan-like feature plus mental retardation. In our question, squinting, subluxation of lens, everything is given. Prone for thromboembolic episode / stroke. And it is pyridoxine dependent condition. So yes, if you know the one question, you can know the tricky question on that concept also. This is a tricky one, but yes, you can know na. Homocystinuria is a pyridoxine dependent condition. Homocystinuria is a pyridoxine dependent condition. Answer this question. My goodness, this question was there 3 times in last 4 years. And I expect you should know this. You should know this. Infant to the hospital, her wet diaper turn black when they are exposed to air. So yes, wet diaper turn black when they exposed to air. Why? See, this is tyrosine. Through its subsequent metabolites, it convert into homogentisic acid. And homogentisic acid in the presence of homogentisic acid oxidase convert into malic acid and fumaric acid. Now what happened? Homogentisic acid oxidase, if this is absent, what happened? Homogentisic acid level will increase in the blood, and this condition is known as Alkaptonuria. Increased level of homogentisic acid leads to one feature in infancy. What feature in infancy? Urine turn black when it exposed to air. And second feature, when child grow, older child, two features will be there. Onchronosis and arthritis. Onchronosis is deposition of black pigment in various body tissue. Onchronosis is deposition of black pigment in various body tissue. See here. Urine turn black when exposed to air. Deposition of black pigment in various body tissue. This is onchronosis. Condition known as Alkaptonuria. And it is due to deficiency of homogentisic acid oxidase. Homogentisic acid oxidase enzyme. Very clear, na? Homocystinuria, Tay-Sachs disease, Alkaptonuria. They ask questions repeatedly on these topics. Clear? Am I clear? Classical question, Alkaptonuria. It is due to deficiency of homogentisic acid oxidase enzyme. Homogentisic acid oxidase enzyme. Am I clear? Answer this question. Read. Just spend 10 seconds, 15 seconds to read the question. Think, then I will come with the answer. You can comment answer in the comment box what you are thinking. 15 days old treated with oral antibiotics for 7 days for suspected sepsis. Now he present in the emergency room, sudden pallor, shock, convulsion and bulging anterior fontanelle. So our approach for this question will start from here. Patient presented with anterior fontanelle bulge. Anterior fontanelle bulging. Now, we look for the associated features. Child presented to you with fever, and convulsion. Fever and convulsion. Fever and convulsion. Bulging fontanelli. Fever, convulsion, bulging fontanelli. It is meningitis. Child presented with bulging fontanelli, pallor and shock. It is intracranial hemorrhage. Child presented with bulging fontanelli and normal physical examination. Mother comes, see doctor, what is bulging? But child is absolutely normal. This condition known as pseudo tumor cerebri. We come to our question again. Bulging fontanelli, but associated feature, pallor and shock. What it indicate? ICH, intracranial hemorrhage, intraventricular hemorrhage. But why it happen? Suddenly it not happen. But we have a predisposing condition for that. Treated with oral antibiotic for 7 days. Oral antibiotic, then child should receive vitamin K. Oral antibiotic disrupt the gut flora. Vitamin K synthesized in gut. So vitamin K deficiency occur. It leads to hemorrhagic disease. So what happen? Bleeding occur in brain. So bulging fontanelli, pallor and shock in a child who is on oral antibiotic for more than 7 days. It is intraventricular hemorrhage. Suppose examiner want that you should put answer B, you should put answer pseudotumor cerebri. Then question will frame like this. Child is absolutely normal. Treated with some antibiotics, tetracycline like, or receive some nalidixic acid for loose motion. Now child develop bulging fontanelli. What is this? Normal examination, fonti bulging, pseudotumor cerebri. Fonti bulging, CNS involvement, convulsion fever, it's meningitis. Fonti bulging with pallor and shock, it is ICH. It is ICH. Answer this question. What is ponderal index? Weight in gram upon height in centimeter cube into 100. Yes, in neonate we take the weight and we take the height and calculate the ponderal index. What is the importance of ponderal index? There is two type of SGA, small for gestation age, asymmetrical and symmetrical. Asymmetrical, ponderal index is always less than 2. Symmetrical, ponderal index is always more than 2. So what is the utility of ponderal index? To classify SGA baby, IUGR baby, small for gestational age baby, whether they are asymmetrical IUGR or symmetrical IUGR. That's the importance of ponderal index. It's very simple. Simple maths. Take the weight of the child in gram, height in centimeter cube into 100. Weight in gram by cube of height in centimeter. It is ponderal index. Neonatology, so many questions on this. What is the formula of ponderal index? This is the formula of ponderal index. Yeah, very good question. Don't go with such a big history based question. Please take FMGE exam also sincerely. Yes, it's my request. You find so many history based question in FMGE exam since last 2-3 years. Their level, they increase the bar very high. The beauty of this, you prepare for FMGE with full strength and see how much preparation of NEET you already done. That's the beauty. See, term 4.2 kg. delivered via cesarean section because of CPD, cephalopelvic disproportionate. Amniotic fluid was clear. Infant cried almost immediately after birth. After 2 hours, respiratory rate is 80. Subcostal retraction present. Grunting is there. After 2 hours. Something serious. Grunting, subcostal retraction, X-ray show fluid in the fissure. X-ray show fluid in the fissure. What is this? What is this? This is TTN. Transient tachypnea of newborn. Transient tachypnea of newborn. TTN. Transient tachypnea of newborn. See, as name denote, it's the transient condition. Baby stable in 48 to 72 hours. But what make baby tachypnic? Normally, in a neonate, in the baby fetus, lungs are collapsed. When baby born, with the first cry, lung expand. Lung expand. When lungs are collapsed, so much water in the lung. When lung expand, all the water get absorbed. But what happen? If there is any delay in the absorption of fluid in the lung, which fluid persist in the lung fissure, that make baby tachypnic. So why? Transient tachypnea newborn. It's a transient condition. Transient, that's why without treatment baby stable within 48 to 72 hours. But why it happen? It is due to delayed absorption of lung fluid which persist in lung fissure in X-ray. Now see, it is associated with male child. Incidence wise, females born stronger, so more problem occur in a male baby. Macrosomia, if weight of the baby is more than or equal to 4 kg. More weight, more water in the lung, get more time to absorb. Caesarean. Normal delivery is a physiological process. Mother had labor pain. Baby travels through the birth canal. This is all physiology. It initiate lung movement. But what happened? What happened in LACS? We do the laparotomy, take the baby out. So there is more chance of TTN in a baby who born with cesarean section. So the policy of few nurseries, if a baby born with cesarean, they kept the baby for at least 6 to 8 hours to watch for TTN. Delayed cord clamping. Just imagine, if you give excessive fluid to the baby, what happen? Baby goes into CHF. Excessive fluid goes into lung. Now, same principle here. When baby delivered, you clamp the cord. If there is a delayed clamping, more fluid, more blood from mother goes to baby. When more fluid goes to the baby, more fluid goes where? Lung. Take more time to absorb. So delayed cord clamping. Excessive maternal sedation. Mother is eclamptic. You sedate the mother during delivery. She is not taking active participation in the process of delivery. It's same like LACS. So these are the 5 conditions which predisposed to TTN. Come to our question. So nicely formed. 4.2 macrosomic male child delivered via cesarean section. Developed tachypnea 2 hours after birth. X-ray show fluid in the fissure. Fluid in the fissure. It is diagnostic of TTN. Simple, na? If you know these things, you concentrate in last 5 minutes, you know about TTN, then you can easily do this question, TTN. So what's the problem? So what's the problem? Now see, answer this question. Answer this question. Very common topic, full of question in all type of exam, whether NEET or FMG. Try to answer this question. Try to answer this question. Yes, Sandeep, Shahid, Payal, what is the answer for this question? Infant of diabetic mother, 32 to 34 week of gestation. So it is preterm. Develop respiratory distress 4 hours after birth. A preterm in which onset of respiratory distress within 6 hours until unless proved otherwise, it is HMD, hyaline membrane disease. Respiratory rate is 80, grunting, duskiness, X-ray show, air bronchogram, another clue for HMD, another clue for HMD. X-ray show, fine air bronchogram. This is HMD, hyaline membrane disease. Yes, something about hyaline membrane disease. Now, risk factor. Preterm, if baby born before 28 week, more than 90% chance baby will have HMD. Male child, maternal diabetes. How? Diabetes to mother leads to HMD in the baby. I will explain. Premature rupture of membrane, female, and maternal hypertension protect against HMD. I will come on this point. Now, what happened? HMD, it is due to deficiency of surfactant. See, this is alveoli. Surfactant produced in alveoli, type 2 pneumocyte, surfactant produced here. It keep the alveoli open. It keep the alveoli open, surfactant. If there is no surfactant, deficiency of surfactant, alveoli collapse. All alveoli collapse. What it leads to? White out lung. It leads to white out lung. Surfactant produced in type 2 pneumocyte. It appear on lung surface 20 week. MCQ. It appear in amniotic fluid 28 to 32 week. Mature more than 35 week. All are MCQs. At what gestation age surfactant appear in amniotic fluid? 28 to 32 week. What gestation age surfactant mature? 35 week. So any baby born before 35, risk of HMD is there. Now come the key point. Steroid and thyroxine increase the surfactant, whether insulin decrease the surfactant. Remember this, I am again repeating. Steroid and thyroxine increase the surfactant. Insulin decrease the surfactant. See here. See, if mother is having diabetes, this is baby, excessive glucose from mother goes to baby. In baby, Iceland of Langerhans are normal. In response to excessive glucose, they start secreting more insulin. They start secreting more insulin. And insulin decrease the surfactant. So baby in which mother is having diabetes, having more insulin, risk for HMD is there. Other side, if mother is having hypertension, in mother's body circulating steroid is more. In hypertension, circulating steroid is more, and steroid increase the surfactant level. Surfactant level increase, so lung get properly mature, so no risk for HMD is there. So infant of diabetic mother, risk for HMD. Hypertension, decrease the risk for HMD. Am I clear? Am I clear? Now see, chest X-ray, come here. This is, what is this? This is white out lung. Or you can say ground glass appearance. All alveoli collapse. All alveoli collapse. this occur in severe form of HMD, ground glass appearance, white out lung, severe form of HMD. And if X-ray you find black dot in between, this is find reticular pattern which is present in moderate form of HMD. Now this is alveoli. Surfactant keep the alveoli open. Surfactant is there but not fully. So what happen? Alveoli will collapse but not fully collapse. They slit like open. So you find black lines in the X-ray. Black lines in X-ray. These are air bronchogram. These are air bronchogram. Air bronchogram present in milder form of HMD. So always remember this thing. A preterm develop respiratory distress, grunting. X-ray shows air bronchogram, mild HMD. X-ray show fine reticular pattern, moderate HMD. X-ray show ground glass appearance, white out lung, severe form of HMD. X-ray, by X-ray we can diagnose HMD. Now, any other way by which we can make out that this distress is due to immaturity of lung? Yes, LS ratio, lecithin sphingomyelin ratio in amniotic fluid. Normally it is more than 2:1, but if it is less than 1.5:1, it indicate lungs are immature. It indicate lungs are immature. Now technology is like that. Radiographer comes in the nursery, took the X-ray, and you see the X-ray on the screen within a minute. But in our days, when radiographer come, they did the X-ray, then they take the film in the dark room, film dry. After many hours, we get the X-ray back. So in our days, any other test we do? Yes, we do the shake test. What we do in the shake test? We take a test tube, and we put gastric aspirate. With the nasogastric tube, we take some gastric aspirate and we add alcohol in this and we shake. When you shake the test tube, liquid, so bubbles will form. A full rib of bubble form means lungs are mature. You are shaking. No bubbles are forming. You are shaking. No bubbles are forming. Means shake test is negative. Negative shake test denote lungs immature. Shake test is used to done maturity of gut, brain, kidney, lung. Shake test is used to assess maturity of lung. We take gastric aspirate 2 ml, we add alcohol 2 ml in the test tube and shake. Bubbles are formed. Drinks complete. Lungs are mature. Shaking. No bubbles are forming. It means lungs are immature. So these all about HMD. See, this is the classical question. Diabetic mother means baby में surfactant तो कम होगा ही होगा. Preterm develop respiratory distress within 4 hours. Grunting, duskiness, X-ray show air bronchogram. What else you want, my friend? This is hyaline membrane disease. Infant of diabetic mother, risk factor for HMD. Hypertension to mother, decrease the risk of HMD. Produce in type 2 pneumocyte, appear on lung surface 20 week. Amniotic fluid 28 to 32 week. Mature at 35 week. Steroid and thyroxine increase the surfactant level. Insulin decrease the surfactant level. Priority by eliciting sphingomyelin ratio and by shake test. Negative shake test and LS ratio less than 1.5:1 indicate lungs are immature. Hope you are getting it well till date. Okay, so these are the important topic. Yes, we are in the middle of 100 MCQ. 100 MCQ. Okay, for target FMGE. Okay, on Medway platform. Myself, Dr. Sanjay Khatri. Yes, answer this question. Another very good classical question, difficult one. If you are reading first time, I give you the clue. It make very easy for you. 2-year-old girl presented with hepatosplenomegaly, short stature, coarse facial features, large tongue, corneal clouding, upper respiratory infection, persistent copious nasal discharge, persistent copious nasal discharge, persistent copious nasal discharge. So these 6 points comes together na. Short stature, organomegaly, कोर्स फेशियल लुक, उसका लुक ऐसा है कि ये कोई सिंड्रोमिक बच्चा है. लार्ज टंग, कॉर्नियल क्लाउडिंग, कोपियस नेजल डिस्चार्ज. दिस इज MPS, mucopolysaccharidosis, and it is Hurler disease. Remember, short stature, hepatosplenomegaly, coarse facial feature, large tongue, corneal clouding, copious nasal discharge. If these 6 words come in a history, you are dealing with MPS, mucopolysaccharidosis. Now, these are the features. These are the features. Coarse facial features, short stature, organomegaly, corneal clouding, large tongue, copious nasal discharge, noisy breathing. But how can you differentiate? Key point, concentrate. All are autosomal recessive except Hunter, which is X-linked recessive. Means present only in boys. X-linked recessive, present only in boys. Now, in history, you are reading corneal clouding. Corneal clouding absent in. No corneal clouding. No. Hunter and San Filippo, no corneal clouding. Remember, hunter, a person who hunt should have a clear vision. Clear vision. Hunter, no corneal clouding. San Filippo, no corneal clouding. Now, they all have some degree of mental retardation, but type 4 and 6, Morique, Marrow, Teoxlemi, in both IQ is. These all are the MCQs. Which of the following having no corneal clouding? Hunter, San Filippo. Which present in only boys? Hunter, because this is X-linked recessive. IQ normal in Morique, Marrow-Teoxlemi. Yes, this is the classical, my friend. Remember this question. Read this question again. Read this question again. 2-year-old girl presented with hepatosplenomegaly, short stature, coarse facial feature, large tongue, corneal clouding. She is having recurrent upper respiratory tract infection, noisy breathing, persistent copious nasal discharge. It is MPS. Why? Because of these classical findings. Why this is Hurler? Because corneal clouding present in Hurler. If no corneal clouding, then it become Hunter. If they present girl, not girl, boy, and all family members are Male. Then answer again hunter, because hunter is X-linked recessive. X-linked recessive diseases, male are affected, females are carrier only. Females are carrier only. Remember, remember, this is MPS, this is classical, IQ normal, Morique and Merotiox Lemmy, 4 and 6, IQ is normal. Answer this question. Basic. You should know about PM. Okay. Read the question and we come to the text first. We read the marasmus first, then we come to the question. So first we read the marasmus. Weight less than 60% of expected. Suppose 1 year, if weight is 10 kg. So 1 year, what is the 60% of 10? 6 kg. If weight at 1 year is less than 6 kg, means less than 60% of expected, this comes into marasmus. Mid-arm circumference less than 11.5 centimeter. Mid-arm circumference less than 11.5 centimeter. Severe wasting, child appear thin, body is made up of skin and bone, no fat. You can see now. See, all bones are prominent. All body is made up of bone, all fat disappear. Old little man appearance, the look of an old man, buccal pad of fat loss, clavicle prominent, all these features are there. So 4 classical point which give you an image how a marasmic kid look like. Weight less than 60% of expected. MSC less than 11.5. Severe wasting, body is made up of bone, no fat. Old little man appearance, buccal pad of fat loss. These 4 give you a picture. In TV, we find some African guys, African kids in bus stand, railway stations, beggars are there, classical marasmic child. But these 4 points give you an image how marasmic kid look like. But 5th and 6th give you the MCQ. Marasmic child is always irritable, not dull. MCQ. Voracious appetite, भूख बहुत लगती है उनको, तो फिर marasmic क्यों हो गए? Puberty के कारण. They didn't get food to eat. Voracious appetite. No anorexia. No anorexia. Voracious appetite. No anorexia. They have a voracious appetite. Now come to the question. All are the features suggestive of marasmus except old little man appearance. True. Irritable. True. Body weight less than 60% of expected. True. Anorexia. No. They have voracious appetite. They have voracious appetite. So simple question. If you know the text of marasmus, how marasmic kid look like, you can answer this question very well. You can answer this question very well. Am I clear? Am I clear? Feature of marasmus. Marasmus kwashiorkor. Last year question on kwashiorkor. We will come on kwashiorkor. Wait. इंतजार करो दोस्त. We will come on kwashiorkor. So first clear the marasmus. Answer this question. Simple, na? This type of question is memory based. If you remember, you can do this and move forward. If not remember, then you're stuck in this, then it creates a lot of problem for other questions also. Kanawati index. It's a ratio of MSC upon HC. MSC means mid-arm circumference. You measure the mid-arm circumference of the child and measure the head circumference of the child and take the ratio. So normal, it will come 0.322 to 0.33. If it is less than 0.25, it indicate severe PM. So Kanawati index, it is age independent criteria. It is age independent criteria to assess PM. No need to ask the age of the child. Just take the MSC, just take the HC, take the ratio. Just take the ratio. Age independent criteria to assess PM. Kanawati index. You should remember. Last 2 years, same question, same language, in biochemistry, pediatrics. Read this question. I am holding. Read this question. Yes, Shahid, Sandeep, answer this. 7-year-old boy brought to the pediatric clinic for growth retardation. Child found to have significant hepatomegaly. X-ray suggestive of aseptic necrosis of femur. Bone marrow examination shows macrophages but look like crumpled tissue paper appearance. Crumpled tissue paper appearance. This is the key. Yes, my friend, it is Gaucher disease. It is Gaucher's disease. Yes, it is commonest lysosomal storage disease. It is autosomal recessive. It is due to deficiency of glucocerebrosidase. It is due to deficiency of glucocerebrosidase. Remember the enzyme. Now, it's a multisystemic involvement. How you will remember? Remember this mnemonic HOB. HOB for Gaucher. H, hematological manifestation. Anemia, thrombocytopenia. O, organomegaly, hepatosplenomegaly. B, bony pain or bony fracture. Simple. Gaucher's commonest lysosomal disease. It's an autosomal recessive disorder. It is due to deficiency of glucocerebrosidase. It shows multisystemic involvement in the form of HOB. Hematological manifestation, anemia, thrombocytopenia. Organomegaly, hepatosplenomegaly. Skeletal, bony pain or bony fracture. Gaucher's disease. Now, here is the key. Splenomegaly is massive. In clinical case presentation, you may get this question so many times. Massive splenomegaly, Gaucher's is one of the cause. Then they show Erler-Meyer flask deformity. Erler-Meyer flask deformity. This is Erler-Meyer flask deformity. See, top narrow, base broad. Same happen with the femur. Like this. Known as Erler-Meyer flask deformity. Erler-Meyer flask deformity is classical of Gaucher's disease. Now, hallmark of Gaucher's is Gaucher's cell. Those present as wrinkled paper appearance, crumpled tissue paper appearance. 2-time question was there in exam. Previous 2 exam FMGE question on Gaucher's. Wrinkled paper appearance, crumpled tissue paper appearance, Gaucher's disease. So remember, this is the classical question. Crumpled tissue paper appearance, wrinkled paper appearance. This is Gaucher's disease. Answer this question. Answer. Common syndrome. Their common heart defect. Lot of MCQs are there. So we start with commonest. Down syndrome. The commonest heart defect in Down syndrome is endocardial cushion defect. This question comes from our age when we are giving the NEET-PG entrance. The most common heart defect in Down syndrome, endocardial cushion defect. Now, Turner. I told you in the Turner syndrome, it's coarctation of aorta. If symptomatic, in asymptomatic, bicuspid aortic valve. Generally, examiner don't want to ask asymptomatic. The commonest heart defect in Turner is coarctation of aorta. Coarctation of aorta. Noonan, pulmonary stenosis. Noonan syndrome, it's pulmonary stenosis. Williams syndrome, it's supravalvular aortic stenosis. This is classical. Our question is also this. Which is the commonest heart defect in Williams syndrome? It is supravalvular aortic stenosis. Supravalvular. What do you mean by supravalvular? This is aortic wall. If aortic wall is narrow, it's bicuspid. If aortic wall is narrow, it is valvular. But what is supravalvular? Above the aortic wall. This portion of ascending aorta is get narrow. Supravalvular aortic stenosis. It is classical of Williams syndrome. Williams syndrome. So remember this. Commonest syndrome and commonest heart defect. Down, endocardial cushion defect. Turner, coarctation of aorta. Noonan, pulmonary stenosis. William, supravalvular aortic stenosis. And my friend, Marfan, mitral valve collapse. So many questions on this. So many questions. Common syndrome, their common defect. Common syndrome, their common defect. Am I clear? Answer this question. The appropriate approach to a female neonate present with vaginal bleed on 6th day of life. Female neonate, vaginal bleed on 6th day of life. What is the problem? Nothing. It's a normal physiology. So no specific therapy is needed. It is due to withdrawal effect of maternal estrogen. It's a normal finding. Any female neonate till 15-16 days of life, if having vaginal bleed, it's a normal finding. It is due to physiological withdrawal of maternal estrogens. So it's a normal finding. Nothing can be done. Yes, this was the question one time they asked. So nothing, no worry, it's a normal finding. Answer this. Which of the following intrauterine infection have maximum chance of vertical transmission during first trimester? Mother is having infection, baby will have infection. This is vertical transmission. Which of the following infection have maximum chance of vertical transmission during first trimester? See, if mother is having toxo, during first trimester, mother is having toxo, chance baby will have 10%. Toxo or say CMV. If mother is having toxo or CMV during second trimester, 40% chance baby will have CMV or toxo positive. Mother is having toxo or CMV positive during third trimester, 90% chance baby will be positive for toxo and CMV. So we can write one line. as gestation age advance, risk of transmission increase. Clear? Logic we know. As gestation age advance, there is well establishment of uteroplacental unit. There is well establishment of uteroplacental unit. So whatever goes to mother is goes to baby. Whatever goes to mother is goes to baby. Clear? Clear? So this rule applicable to all except rubella. If mother is having rubella during first trimester, chance baby will have rubella 80%. If mother will have rubella during second trimester, it's 36%. Mother having rubella during third trimester, again it is 90%. So mother is having rubella, mother is having toxo, CMV, herpes, HIV, whatever, chance baby will have infection is only 10%. But if mother is having rubella during first trimester, chance baby will have rubella is 80%. So which of the following intrauterine infection have maximum chance of vertical transmission during first trimester? It is rubella. Am I clear? Am I clear? Now, simple. Chance of transmission of rubella from mother to baby. Maximum occur first trimester, it is 80%. Second trimester, it is 36%. Third trimester, it is 90%. This was the question in DNB exam. Entrance 4-5 years back when they are separated from NEET. It is third trimester. It is third trimester. Clear? Clear? So, if any infection occur in first trimester, 10% chance. Second trimester, 40% chance. Third trimester, 90% chance. Exception is rubella. If rubella occur in first trimester, 80%. Second trimester, 36%. Third trimester, 90%. So chance of rubella maximum occur during third trimester. But if we consider first trimester, which vertical infection having maximum chance of vertical transmission during first trimester? It is rubella. Now, another law you see. First trimester, mother got rubella. 80% chance baby will have rubella. But if baby have rubella, so what are the feature in the baby? Deafness, cataract and CHD. If second trimester mother got rubella infection, so what happened? 1/3 will have deafness, 2/3 is absolutely normal. No one have cataract or CHD. If mother develop rubella during third trimester, all are normal. So we can say one word: as gestation age advance, severity of disease decreases. As gestation age advance, severity of disease decreases. Logic you know. First trimester is a period of organogenesis. If any insult occur during that time, all organs are involved. Like that, if rubella occur in first trimester, all the baby will have deafness, cataract and CHD. But if rubella occur during second trimester, heart septation complete, eye lens complete, internal ear development take place to 18 and 20th week, so still few have deafness. But if rubella occur during third trimester, all baby borns normal, they are just positive for rubella antibody, that's all. Because organogenesis is completed. Organogenesis is completed. So this is important line. Mother during 8th, 9th, 10th week of pregnancy develop fever, rash, joint pain, comes positive for rubella. 80% chance baby will develop rubella and baby will have deafness, cataract, CHD, all. Mother at 32 week, 34 week, 37 week of pregnancy develop fever, joint pain, rash, positive for rubella. No worry, nothing will happen in the baby. Baby is positive for rubella, that's sure. But all organs form till that time, so no problem occur in that baby. So we can say as gestation is advanced, severity of disease decreases. Logic we know, first trimester is the period of organogenesis. This comes from ages. I use the word ages. You should remember triad of rubella. Triad of rubella. Deafness, cataract, CHD. Triad of rubella. Deafness, cataract, CHD. Triad of toxo. Triad of toxo. Chororetinitis, diffuse cerebral calcification, hydrocephalus. Remember these things. CMV, nothing used as a triad, but CMV shows periventricular calcification. Toxo shows diffuse cerebral calcification. Congenital varicella syndrome. Cerebellar hypoplasia and limb hypoplasia. You should remember these features. We will practice the question on this, but you should remember triad of rubella, triad of toxo, CMV classical feature, congenital varicella syndrome. Come. Now, these are older, but new thing you also remember. If mother develop parvovirus infection during pregnancy, what happened in the baby? Non-immune hydrops fetalis. Mother develop HIV. If baby positive for HIV, will have failure to thrive, calcification of basal ganglia and severe thrush. Mother develop Zika virus during pregnancy. What feature occur in baby? Microcephaly, lysencephaly, cerebellar hypoplasia, subcortical calcification, retinal mottling, macular scarring. Now see, what is lysencephaly? Lysencephaly is smooth brain. This is the brain. This is normal brain. But if you find brain like this, a smooth brain, no gyri, no sulci, smooth brain, it is lysencephaly. So very good MCQ. Na? Baby born with lysencephaly, which intrauterine infection you are suspecting? It is Zika virus. Lysencephaly, smooth brain, no gyri, no sulci, no gyri, no sulci. Now, if you have concentrated in the previous questions, you can answer this question. All of the following have hepatosplenomegaly except. I told you Tay-Sachs. No hepatosplenomegaly. No hepatosplenomegaly. Tay-Sachs disease. No hepatosplenomegaly. I told you 6 feature of Tay-Sachs. Macrocephaly, cherry red spot, neurodevelopmental regression, exaggerated startle response, no hepatosplenomegaly, no treatment. 6 feature, hexa, and it is due to deficiency of hexaminidase A. It is due to deficiency of hexaminidase A. Tay-Sachs disease. Answer this question. Marasmus we have read. This about kwashiorkor. Marasmus we have read. This about kwashiorkor. Answer. You can answer this question. So first we read the text, then we come to this question. For kwashiorkor, we have essential criteria and we have non-essential criteria. Essential means you need these three criteria to make the diagnosis of kwashiorkor. Essential means growth retardation, weight between 60 to 80% of expected, mental changes, child is dull, apathic, no interest in surrounding, and edema is there. You can't make the diagnosis of kwashiorkor without edema, without mental changes, child is dull, without growth retardation. Weight should be 60 to 80%, child should be dull, apathic, no interest in surrounding, and having edema. These are must. These are non-essential. May or may not be there in a kwashiorkor child. But yeah, in few patients, these are there. Hair sign, flag sign. If you see the hair of kwashiorkor patient, in some patient, you find alternate band of pigmented and depigmented. Flag sign, flag sign. Skin changes, flaky paint dermatosis, hyperkeratotic patches over skin, flaky paint dermatosis. Other hepatomegaly, fatty liver, anorexia, chillosis. These are non-essential feature. Yes, anorexia is a feature of kwashiorkor, not the marasmus. Hepatomegaly is a feature of kwashiorkor, not the marasmus. Got my point? So now, what is the diagnostic of kwashiorkor? Kwashiorkor diagnosed in a growth retarded child with, now it's simple, na? Now it's simple, edema and mental changes. Edema and mental changes. Am I clear? Am I clear? Because essential feature of kwashiorkor, growth retardation, mental changes, edema. Growth retardation, mental changes, edema. Clear? Clear? Marasmus, 6 point. Weight less than 60% of expected. Mid-arm circumference less than 11.5. Body is made up of bone. Old little man appearance. Voracious appetite. Irritable child. Got it? Kwashiorkor, essential, non-essential. Essential, growth retardation, mental changes, edema. And non-essential, hair change, skin change, hepatomegaly, fatty liver, chillosis, and anorexia. Clear? So these are the basic topic. You can't imagine an exam of pediatrics without a question on marasmus, kwashiorkor, diarrhea. These are the common. Without the question on Turner, Down, Fragile X. These are frequently asked. And metabolic diseases, they make the paper little tricky. Alkaptonuria, Homocystinuria, Gaucher's disease, Tay-Sachs disease. All of them we have clear concept in this class on Medway platform. So we are in the middle of a very good class in which I am covering impressive, important, most probable 100 questions for you. Yes, at least you should know and get hold over these questions. Answer this question. Such a classical points written in this. Large tongue, organomegaly, floppy limbs. Floppy child with large tongue. X-ray show cardiomegaly, ECG show short PR interval. This is P, this is R. So normally we saw P with some distance R. But if you find this on ECG, P, R, P, R, short PR interval, short PR interval, short PR interval, it is diagnostic of Pompey's disease. Pompey's disease, short PR interval, it is diagnostic of Pompey's disease. Floppy baby, cardiomegaly, short PR interval on ECG. This question asked 2 times. So they asked the enzyme, actually name of the enzyme. Which enzyme deficient in Pompey's disease? Acid maltase enzyme. Acid maltase enzyme. It is lysosomal storage of glycogen. Result from lysosomal storage of glycogen in skeletal muscle, cardiac muscle and CNS. Classical feature, floppy baby, large tongue, progressive cardiomyopathy. ECG show short PR interval. ECG show short PR interval. Answer this question. Again, this is the basic question from vitamins. Read this question and try to make a answer. So, what is the treatment for vitamin A deficiency? It will depend upon age of the child. Less than 6 months, 6 to 12 months, more than 12 months. Less than 6 months, 50,000. 6 to 12 months, 1 lakh. And more than 2 months, 12 months, 2 lakh. Today, day after, and after 4 weeks. So our child is 9 months. 9 months. So 9 months means it comes in 1 lakh category. So 2 lakh is out, 2 lakh is out. So 1 lakh. Same day, next day, 4 week later. This is right. Why I am telling? Bitot spot and conjunctival cirrhosis means vitamin A deficiency is there. So what is the schedule for treatment? 6 month, 50,000. 6 month to 12 month, 1 lakh. And more than 12 month, 2 lakh. Now, less than 6 month, 50,000. 6 month to 12 month, 1 lakh. Our child is 9 month, comes in this category. So 1 lakh, same day, next day, 4 week later. Remember this, remember this. Again, this is a universal question. Which vitamin deficiency leads to neonatal seizure? It is pyridoxine. Pyridoxine. Pyridoxine deficiency leads to neonatal seizures. After Down, Turner, Patau, now they shift to DiGeorge syndrome. These questions are very common in national board question paper. Okay, DiGeorge. So it may come in FMG. It's very simple, very simple. All the features of DiGeorge syndrome, except it will take 1 minute and will definitely give you some question in the exam. Now, DiGeorge syndrome, also known as 22q deletion syndrome, 22q11 deletion syndrome, catch 22, this is the acronym. Catch, C for cardiac defect, A for abnormal phases, T for thymic aplasia. When thymus is abnormal, there is a T cell immune deficiency. C for cleft palate, H for hypoparathyroidism and hypocalcemia. Hypoparathyroidism and hypocalcemia. Hypoparathyroidism and hypocalcemia. Now see, there are so many questions on DiGeorge syndrome. You need to remember catch, 22q11 deletion, catch. C for cardiac defect. Interrupted aortic arch, truncus, TOF. There are so many, but you remember cardiac defect. A. Abnormal feces. T. Thymic. C. Cleft palate. Hypoparathyroidism, hypocalcemia. Come to the question. Now it's very simple. When thymic aplasia, recurrent infection will be there. When we are talking abnormal faces, then mandible hypoplasia will be there. Impaired B cell function, no, 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 no. There T cell deficiency. And hypocalcemic seizure, yes. All gland involved in DiGeorge syndrome except thymus, yes. Parathyroid, yes. Thyroid, no. So just simple. You can do every question on DiGeorge syndrome. Just remember catch 22. Catch 22. Catch. Remember what is C, what is A, what is T, what is C, what is H. 22 means it's 22q11 deletion syndrome. Am I clear in DiGeorge syndrome? Am I clear in DiGeorge syndrome? Now, familial hypophosphatemic rickets, all are true except. One day we will read rickets also in the long class, half an hour topic. But this is the exam time and we are touching the important points. So I am giving you the two classical points by which you can solve all the questions on rickets. Hypophosphatemic rickets is also known as vitamin D resistant rickets. Okay, the first point, most common non-nutritional form of rickets. Second point, it is X-linked dominant ricket. Third point, defect in the absorption of phosphorus in renal tubule. And phosphorus loss, that's for hypophosphatemic rickets. Okay, now PTH level is elevated. No, 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 no. In hypophosphatemic rickets, vitamin D resistant rickets, PTH is normal. PTH is normal. PTH is normal. PTH is normal. You remember this thing. These 3 points about familial hypophosphatemic rickets, and last point, PTH normal, PTH normal, PTH normal. You are able to solve your question in exam. One way, remember rickets for half an hour, all the concept mechanism which I teach you in some other day. But to remember, hypophosphatemic rickets or vitamin D resistant rickets is one and the same thing. Hypophosphatemic, defect in the absorption of phosphorus. It is most common non-nutritional form of rickets. It is X-linked dominant and PTH is normal. PTH is normal. PTH is normal. Am I clear? Am I clear? PTH is normal. Yeah. Anticipation phenomena means severity of disease increase with successive generation. Severity of disease increase with successive generation. Anticipation phenomenon. It is determined by triple codon transmission. What are the diseases which shows anticipation phenomena? Huntington chorea, yes. Fragile syndrome, yes. Friedreich's ataxia, yes. Duchenne muscular dystrophy, no. So which dystrophy shows anticipation phenomena? It is myotonic muscular dystrophy. So it's a myotonic muscular dystrophy which shows anticipation phenomena. So anticipation phenomena, Huntington chorea, Fragile X syndrome, Friedreich's ataxia, and myotonic muscular dystrophy. It's not Duchenne muscular dystrophy. Am I clear? Am I clear? Anticipation phenomena seen in all of the following except Duchenne muscular dystrophy. Yeah, simple question. Handedness. When you say a child is left-handed or child is right-handed. Yeah, if you know, then it's okay. If you don't know, answer will surprise you. After 3 years of age, we come to know whether child is lefty or righty. So correct answer would be 36 to 40. Suppose a 2-year-old child preferentially uses right hand, it means something wrong in the left, or using the left hand, something wrong in the right. Means handedness usually determined by the age of 36 to 42 months. Handedness usually determined by age of 36 to 42 months. Okay, handedness more than 3 years. Clear? Clear? Now, this is the question. So many times this happen. So many times it asks. I will make the concept clear to you. Primary teeth 20 in number. Secondary teeth 32 in number. Primary teeth is also known as decidual teeth. Secondary teeth is also known as permanent teeth. So, first teeth to erupt in an infant, lower central incisor. This is MCQ. Last to last year, this was asked in FMGE exam. First teeth to erupt in an infant, lower central incisor. Lower central incisor. Now see. Lower central incisor. Lower central incisor. 6 to 8 month of age. Now, one lower central incisor is this, another will be here. Central incisor. Central incisor. 6 to 8 month of age. This is also central incisor. This is also central incisor. 6 to 8 month of age. Then comes the lateral incisor. 8 to 10 month of age. Lateral incisor. Then comes the molar one. 10 to 16 month. 10 to 16 month. This is molar one. Then come the canine. 16 to 20 months. This is canine. Then come the molar 2. 20 to 38 month. Molar 2. So see here. One tooth represent 4 teeth. So here total number of teeth 4. Here total number of teeth become 8. Here total number of teeth become 12. Here total number of teeth become 16. Here total number of teeth become 20. So all 20 teeth appear by the age of 30 month. 30 month means 2.5 years. See here, all primary teeth typically erupt by the age of 20 to 30 months. 20 to 30 months. 20 to 30 months. No, I will not move further. If any confusion is there, I will try to clear. This is central incisor. This is lateral incisor. This is molar 1. This is canine. And this is molar 2. Central incisor 6 to 8 months. Lateral incisor 8 to 10 months. Molar 1 10 to 16 months. Canine 16 to 20 months. Molar 2 20 to 30 months. Clear? So see, central incisor 6 to 8 months. Number of teeth 4. Because this is central incisor, this is also central incisor, this is also central incisor, this is also central incisor. So one tooth represent 4 teeth. Lateral incisor 8 to 10 months. So number of teeth become 8. Molar 1 10 to 16 months. So number of teeth become 12. Then comes the canine 16 to 20 months. So number of teeth become 16. Then come the molar 2. So number of teeth become 20 to 30. That is 20. Clear? All primary teeth erupt by the age of 20 to 30 months. First teeth to erupt. Central incisor, lower central incisor. My request, remember this thing, full of question on this concept. Now, typical question on developmental milestone. One way we learn all the developmental milestone, but this is not the time that we should go through the each and every milestone, but key milestone we will remember. Child who skip means jump on 2 legs. Jump on 2 legs. Name 4 colors. Dress, undress without assistant. This is gross motor, this is linguistic, and this is social. These milestones belong to 5 year of age. And 5 year means 60 months. 5 year means 60 months. How old a child who skip? Name 4 colors, dress and undress without assistant. 60 months or 5 years. Classical question. All are live vaccine except. I want answer from you. Anybody? All are live vaccine except. How you remember name of live vaccine? This is mama's boy. We are mama's boy. We are mama's boy is live vaccine formula. V means varicella. R means rotavirus. M means measles. Second M means MMR. B means BCG. O means OPV. Y means yellow fever. No other way to remember live vaccine. Name of the live vaccine. So all are live except BCG live, rotavirus live, varicella live. Rabies is a killed vaccine. Rabies is the killed vaccine. Am I clear? Live vaccine. So how you remember the name of the killed vaccine? Harry. Harry. HA, hepatitis A. R, rabies. I, influenza. So simple, my friend. Live and killed vaccine. Don't you see? All are live except, all are killed except. Simple concept. Remember this. Live vaccine. We are mama's boy. Live vaccine. Varicella, rotavirus, BCG, OPV, MMR, yellow fever. Killed vaccine, Harry, HARI. Hepatitis A, rabies, and influenza, and IPV, both you can consider. Then recombinant vaccine, hepatitis B, polysaccharide vaccine, you should remember meningococcal, pneumococcal, Hib, and typhoid. Those are polysaccharide vaccine. Can you believe this was the question in AIMS, INI-CET 2020? Which of the following is a toxoid group vaccine? Diphtheria and tetanus. So this question is there in their question bank. Why not they ask from you, FMG people? Which of the following is toxoid vaccine? Diphtheria, tetanus. Which of the following is a polysaccharide group of vaccine? Meningococcal, pneumococcal, Hib, and typhoid. Which of the following is a recombinant vaccine? Hepatitis B. All are live except, all are killed except. This is the simplest way, my friend. Remember this. Remember, live and killed vaccine. Live and killed vaccine. Live and killed vaccine. Remember, all are live vaccine except rabies is killed, rest all are live. Am I clear? Now, if you remember just 5 minutes back, you can answer this. Correct sequence of eruption of primary teeth is central incisor 6 to 8 months, lateral incisor 8 to 10 months, first molar 10 to 16 months, and canine 16 to 20 months. Correct answer would be C. Central incisor, lateral incisor, first molar, and canine. Central incisor, lateral incisor, first molar, and canine. Correct sequence for eruption of primary teeth is central incisor, lateral incisor, first molar, and canine. Clear? So, you know the sequence. You know the first teeth to erupt. All teeth erupt by the age of 20 to 30 months. You should remember. Trust me, these all are the question in previous years FMG papers. So you know the clear concept of eruption of teeth. So these are. Answer this question. If you know this thing, it will be easy. Else, you are not able to answer. Uric acid estimation in children required in hyperuricemia. When you are suspecting hyperuricemia in patient of self-mutilation. Self-mutilation means self-injurious behavior. Patient will do head banging to the wall. Try to bite the finger. Initially nail, finger, terminal stage, पूरी finger amputate कर देता है. Self-mutilation, self-destructive behavior occur when there is a hyperuricemia, and it's a feature of, yes, you are right, Lesch-Nyhan syndrome. If child comes to us with a feature of self-mutilation, so we first do the uric acid level. If it is increased, then we suspect it's a Lesch-Nyhan syndrome. Then we do the enzyme HPGRT deficiency. Lesch-Nyhan syndrome, self-mutilation, self-destructive behavior is a feature of Lesch-Nyhan syndrome. It's a feature of Lesch-Nyhan syndrome in which uric acid level is very high. Which of the following syndrome, if occur in male, is lethal? All X-linked dominant syndrome, if occur in male, is lethal. X-linked dominant present only in female. And there are only 5 exclusive X-linked dominant syndrome. Only 5. Only 5. Hypophosphatemic rickets, Rett syndrome, Gold syndrome, Aicardi syndrome, incontinentia pigmenti. These are, if present in male, they die in utero or early infancy. They manifest only in female. So our question, which of the following syndrome occur in male is lethal? Yes, Rett syndrome occur in male is lethal. Either they die in utero or early infancy. Either they die in utero or early infancy. Rett syndrome. Rett syndrome. The classical feature of Rett syndrome, wringing movements of hand. You find patient of Rett syndrome will do like this, wringing movements of hand. Rett syndrome. In a girl, it's not occur in a boy. Not occur in a boy. Wringing movements of finger. Yeah. Classical question. Read. I give you the time for 2 minutes to think about it and then you can answer. Think. Try to answer in a comment box if you can. 2-year-old child, well, except for fever. 4th day, develop a rash. 4th day rash. Fever. 4th day rash. Measles. But what is the classical of measles? When 4th day rash appear, fever, shoot. Child is having 99 fever, 4th day rash appear, fever become 104. But look at our question. Look at our case. As rash appear, temperature returns to normal. So it can't be measles, because in measles 4th day rash appear, as rash appear fever shoot, as rash appear fever shoot. But here as rash appear temperature returns to normal, so it can't be measles. Here fever 4th day rash, as rash appear fever become, it is classical of roseola infantum, also known as 6th disease, caused by human herpes virus type 6. Fever 4th day. 4th day rash appear and temperature returns to normal. It is roseola infantum, also known as 6th disease, human herpes virus type 6. Fever 4th day rash and fever increase It is classical of measles. Measles, previous 2 year question was there. We will do the question of measles, but first get a correlation of rash and fever. Which day of fever rash comes? Base the diagnosis. First day fever rash, it's varicella. Second day fever rash, scarlet. Third day fever rash, smallpox. Fourth day of fever rash, measles. Fifth day of fever rash, typhus. Sixth day of fever, dengue. And seventh day of fever, enteric. How you will remember? Very sick people must take daily egg. It's very good mnemonic. You may find it's not given by me. I am not take credit of this. This my senior taught me some 25 year back when I was doing MBBS. Yes. Which day of fever rash appear? First day fever, same day rash, it's varicella. Second day rash, scarlet fever. Fourth day rash, measles. Whenever measles occur, fever shoot. But with rash, fever comes down. It's not measles, it's roseola infantum, sixth disease caused by human herpes virus type 6. Now, read this question. This is the classical question on measles. Four-year, present with fever, conjunctivitis, cervical adenopathy, and chorea. 3C of measles: conjunctivitis, cervical adenopathy, chorea. Gray lesion surrounded by erythema on buccal mucosa. Rash also noted on fourth day of fever. Now the key point. As rash appear, fever rises. It has to be measles. Fourth day rash. As rash appear, fever shoot. It is measles. As rash appear, fever shoot. It is measles. It is measles. As rash appear, fever disappear. It's roseola infantum. But as rash appear, fever rise. It's measles. Trust me. 3C of measles. This question last 2 year in exam. Answer this question. Not defreeze. This is freeze and this is gate of the freeze. This is first freezer. This is first compartment. This is second compartment. This is third compartment. Door. No vaccine should be kept at door. Freezer, we keep only OPV. First compartment, we kept BCG, measles, and MMR. Base, we kept diluent, normal saline distilled water. Rest all vaccines in second compartment. Now, our question, which of the following vaccines should not be deep freezed? Okay. OPV you keep in the freezer. You can keep BCG, measles and MMR into the freezer. No harm. No harm. But all vaccine in which T letter comes, whether it's DPT, it's TT, it's DT, it's hepatitis T, you can't keep in the freeze compartment. T can't keep in the freeze compartment. Why? Because by mistake you kept DPT in freezer. its adjuvant preservative is aluminum hydroxide, which get destroyed. And if you keep DPT in freezer and that DPT you give to the patient causes sterile abscess. So which vaccine should not be defrizzed? It is T containing vaccine, DPT. Clear? Such a basic question. Such a basic question. Which vaccine should not be defrizzed? All vaccine in their spelling T word comes should not be defrizzed. Just to remember, DPT and hepatitis TT, these vaccines are not defrizzed. Clear? Clear? Ah, it's a very good question on developmental milestone. Very basic milestone, very basic milestone. You should know when child can make a circle, when child can make plus and square, cross and triangle. Child can make a circle at 3 year, plus and square at 4 year, cross and triangle at 5 year. Cross and triangle at 5 year. So correct sequence, copy a square 4, cross 5, circle 3. So this is not the correct sequence. By this, if we reach to the fourth one, circle 3, square 4, cross 5, D is the right answer. So why you are not putting in the comment box D? Just remember, these are universal milestone. Child can draw a circle at 3 year of age, plus and square at 4 year of age, cross and triangle at 5 year of age. ये नहीं पूछना उसको 1 साल लगता है क्या सर्कल से स्क्वायर सीखने में? Yes, these are the ideal milestone given by IAP. Circle at 3 year, plus and square at 4 year, cross and triangle at 5 year. 5 year, cross and triangle at 5 year. Remember this thing. These developmental milestone you should remember. Yeah. Activity shown in pic is done by child earliest at which of the following age? What is this? Tower of 1, 2 and 3 cubes tower. So just remember, you may find question on this. Child can make tower of 2 cubes at 15 months. Tower of 3 cubes at 18 months. Tower of 6 cube at 24 months. And tower of 9 cubes at 36 months. Remember, tower of 2 cubes 15 months. Tower of 3 cubes 18 months. Tower of 6 cube 24 months. And tower of 9 cube 36 months. 36 months. Okay, in our question, child can make tower of 3 cubes. 3 cubes at 18 months. Child can make tower of 3 cubes at 18 months. Clear? Clear? Just remember, they can ask you, child can make tower of 9 cubes, 3 years. Child can make tower of 6 cube, 2 years. Child can make tower of 3 cubes, 1.5 year, 18 months. And tower of 2 cubes at 15 months. So remember these things very well. Oh, now one way we can remember the milestone as whole. Another way, we remember the common milestone with the age. So 2-year-old child. Yes, he can run well, speak simple sentence, I want water, बाहर जाना है, turn one page of a book at a time. एक बारी में एक ही पेज टर्न करेगा. 1 साल से छोटा 3-4 पेज एक साथ टर्न करेगा. Tell his or her name. No, this is the milestone of 3 years. When child can tell his or her name, बच्चा क्लिनिक में आता है, बेटा व्हाट्स योर नेम, 3 ईयर का है तो अपना नाम बताएगा, 3 ईयर, टेल हिज और हर नेम. सो विच ऑफ द फॉलोइंग इज इनकरेक्ट, ये तो आपको याद रखना ही है. व्हेन चाइल्ड कैन टेल हिज और हर नेम एट 3 ईयर, this is not the milestone of 2 years, this is not the milestone of 2 years. You should remember, you should remember. Now simple, just read for just 30 seconds, then I can explain each and every milestone of 2 and 3 year. This is the best way to remember milestone in just fun. Gross motor, 2 year, run well, kick a ball, upstairs, downstairs with 2 step. Child is standing here, अगले स्टेयर पे, फिर अगला पैर भी इस स्टेयर पे रखेगा, अगले स्टेयर पे, फिर अगला पैर भी इस स्टेयर पे रखेगा. अपस्टेयर, डाउनस्टेयर विथ 2 step. Gross motor. Fine motor, vertical stroke. Child can draw a stroke like this. Tower of 6 cube, we just learn. Turn one page of a book at a time. Linguistic, simple sentence. Child can speak simple sentence. पानी दे दो, बाहर जाना है. Simple sentence. Social, dry by day, means day time में child can tell about, yes, toilet लगा है. Dry by day. 2 year, again repeat. Run well, kick a ball, upstairs, downstairs, 2 step. Fine motor, vertical stroke, tower of 6 cube, turn one page of a book at a time. Linguistic, simple sentence. Social, dry by day. 3 year, ride a tricycle, again important milestone. Upstairs by single step. See, child is lying here, एक स्टेप इस पे, अगला उसके ऊपर, अगला उसके ऊपर, अगला उसके ऊपर. Single step. Upstairs by single step. Fine motor, you remember circle and tower of 9 cube. Linguistic, you remember age, name and gender. A 3-year-old child can tell his or her name, age and differentiate between boy and girl. Social, dry by night. 3 year में चाइल्ड नाइट में भी टॉयलेट के बारे में बताता है. तो जस्ट इतना सिंपल है. 5 year के हमने याद किए थे. स्किप, नेम फॉर कलर, ड्रेस अनड्रेस विदाउट असिस्टेंट. 2 and 3 year, just stuck on that. Repeat, 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 because it's exam time. You need to remember things in a faster way. This is the way. 2 year milestone, 3 year milestone. We do application on this. Child can do, 2-year-old child, yes, run well, speak sentence, turn one page of a book at a time, tell his or her name. No, this is the milestone of 3 year. 2 year, 3 year. Few more application based, then it will be clear. Few more application based, then it will be clear to you. Yeah, answer this. I will not move. Answer this question. Child who can tell his name, ride a tricycle, means tell his name, 3 year हो गया. Ride a tricycle, 3 year हो गया. But does not goes to toilet alone, this is the milestone of 4 year. So what is the approximate age of the child? Child is bigger than 3 but not achieve 4 year, because 4 year का milestone उसको आता नहीं है. टॉयलेट के माइलस्टोन क्या होते हैं? ड्राई बाय डे, 2 year. Dry by night, 3 year. Goes to toilet alone, 4 year. So child can able to do the work for a 3 year but not 4 year. So age of the child is between 3 to 4 year. Between 3 to 4 year. Am I clear? Am I clear? So this is the way you remember the milestone. Remember the milestone. Just do few questions. Just remember few things. Child नाम कब बताएगा? 3 साल पे. Simple sentence 2 साल में. Dry by day 2, dry by night 3, goes to toilet alone 4. Simple. Run a ball, kick a ball 2 year. Ride a tricycle 3 year. Simple. याद तो करना ही पड़ेगा ना. आपका एग्जाम है, आपको याद करना पड़ेगा. I will help you. Okay. So gross motor, fine motor, linguistic and social, milestone of 2 and 3 years. Remember this. Answer. Hypotonic, hyporesponsive episode occur with which vaccine? वैक्सीन लगाते ही बच्चा हाइपोटोनिक हाइपोरिस्पॉन्सिव हो गया. कौन सा वैक्सीन? डीपीटी. डीपीटी. We should remember some classical points, contraindication and not contraindication of DPT, because there are lot of question on DPT vaccine. Absolute contraindication for DPT, progressive neuromuscular disease. If any child is having progressive neuromuscular disease, हम DPT नहीं लगाएंगे. Encephalopathy within 7 days of previous dose, हम DPT नहीं लगाएंगे. हम DPT नहीं लगाएंगे. तो absolute contraindication, progressive neuromuscular disease and encephalopathy within 7 days of first dose. Relative contraindication. Hyperpyrexia. DPT से फीवर हमेशा आता है. 99, 99.5. क्रोसिन ड्रॉप हमेशा देते हैं DPT के साथ. पर इस बच्चे में फीवर आ गया 104, 105. हाइपरपायरेक्सिया. इट मींस DPT रिएक्टोजेनिक है इसमें. नेक्स्ट डोज मत लगाना. मे बी चाइल्ड गोज इनटू एनकेफेलोपैथी. हाइपरपायरेक्सिया. कन्वर्जन विदिन 72 आवर. इनकंसोलेबल क्राई. DPT पे लोकल साइट पे पेन होता है. लोकल साइट पे पेन होगा DPT में, पर 2 मिनट 3 मिनट 4 मिनट में बच्चा ठीक हो जाएगा. इनकंसोलेबल क्राई. लगातार रो रहा है बच्चा, लगातार रो रहा है. इनकंसोलेबल क्राई फॉर मोर देन 3 आवर. अगला DPT नहीं लगाइए. DPT रिएक्टोजेनिक है इसमें. हाइपोटोनिक हाइपोरिस्पॉन्सिव एपिसोड. आपका MCQ आया अभी. Which vaccine leads to hypotonic hyporesponsive episode? It is DPT. LGB, Guillain-Barre syndrome, within 6 weeks of DPT. So these 7, 2 plus 5, 2 are absolute, 5 are relative contraindication for DPT. For all practical purposes, if this 7 is there, we not give second dose of DPT. Absolute contraindication for DPT. LGB, hypotonic hyporesponsive episode, convulsion, inconsolable cry, hyperpyrexia, progressive neuromuscular disease, encephalopathy within 7 days. To remember them in a best way, it's best to remember not contraindication. आपका क्वेश्चन कभी फंसेगा नहीं. Not contraindication for DPT. Family history of convulsion is not a contraindication for DPT. Family history of convulsion. Non-progressive neuromuscular disease such as cerebral palsy. Non-progressive neuromuscular disease is not a contraindication for DPT, and febrile convulsion is also not a contraindication for DPT. So remember, family history of convulsion, non-progressive neuromuscular disease and febrile convulsion is not a contraindication for DPT. Those 7 are the contraindication. These 3 are not contraindication. You will able to do all the questions regarding DPT. Contraindication, not contraindication. This is common. Toxic shock syndrome likely to occur with which of the following vaccine? C. Measles vaccine. provided in dry powder. We add MD, distilled water, in measles to reconstitute the vaccine, and this vaccine should be used within 3 hours. आपने वैक्सीन को रिकंस्टिट्यूट किया सुबह 9 बजे, 12 बजे तक यूज कर लो, नहीं तो डिस्कार्ड कर दो. डिस्कार्ड नहीं किया और 2 बजे लगा दिया किसी को, हाई प्रोबेबिलिटी ऑफ टॉक्सिक शॉक सिंड्रोम. Which vaccine likely leads to toxic shock syndrome? It's a measles vaccine. If not used in his time limit, less than 3 hours, if not, discard that vaccine. Discard. If still you use, it can lead to toxic shock syndrome. Toxic shock syndrome with measles vaccine. Late complement deficiency is an absolute indication for which of the following vaccine? I expect from you people to answer this question. Late complement deficiency, C5 to C9. Late complement deficiency. Late complement deficiency is there. Individual is prone for meningococcal infection. If late complement deficiency is there, it's an absolute indication to give meningococcal vaccine. Else, child will have life-threatening meningococcal septicemia. So what is the absolute indication for meningococcal vaccine? It's late complement deficiency, and it was asked in previous exams. Late complement deficiency, meningococcal vaccine. Answer this question. Very practical question, very practical. Child receive full course of hepatitis vaccine. What serological response occur in the child? Suppose after your FMG exam, you want to work in some hospital, you want to work clinical side, or after NEET, you join some hospital, and after doing your MD, DNB, MS, you are joining some corporate hospital. So they will check your medical record, they check all the blood investigation. They want that you should be immune with hepatitis, you should be HIV negative, BCG, TB negative. So they check everything. So you show them that paper, say this is my card, I receive hepatitis vaccine. No, no, no. They will not. They will not. They, in their blood, they check anti HBs AG. It should be more than 10 international unit. Then you are immune. Means you received 3 doses of hepatitis vaccine. You received 3 doses of hepatitis vaccine. If your blood has anti-HBs AG level more than 10 and you are immune. We all are doctors. We work in the emergency. Sometime a sick patient comes and we try to put a line, we intubate the baby, and suddenly we develop a prick. And later we come to know that patient you intubated that day, you did the everything to save the child, life of that child, and that child was hepatitis positive. No worry, check your anti-HBs AG. If it is more than 10, you are immune. So there are so many questions on serological marker in hepatitis infection. See, this is HBs AG. This is envelope antigen. This is antibody core, and this is antibody. Just remember, you will understand each and everything. Just hold. This is HBe antigen. This is hepatitis surface antigen. This is anti HBC, core antibody, and this is anti-HBS antibody. Now see, MCQs. 1. Surface antigen. 1. This is the earliest. 2. 2. This is the marker of infectivity. If individual is having envelope antigen, that individual is highly infectious. Highly infectious. Earliest is surface antigen. Envelope not present in everybody. If it present, it highly infectious. Anti-HBC, third. Once appear, persist lifelong. And surface antibody present, anti-HBS, only when surface antigen disappear, then it present. So fourth, it's a marker of immunity. If your sera contain only at anti-HBS, it means you are vaccinated. Only anti-HBS is due to vaccine. If your sera contain both core antibody and surface antibody, it means past you have hepatitis B infection, it's recovered, but your sera contain both antibody, core and surface. If your blood sera contain only surface antibody, it is because of vaccine. You are immune. So this is earliest. This is a marker of infectivity. This persists, core antibody persists lifelong, and surface antibody indicate you are immune. This is clinical. This is most important question, whether considered pediatrics, PSM, or biochemistry or microbiology. Serological marker in hepatitis B infection is one of the most important topic and concept. Simple. Mother is taking lithium during pregnancy. Most common anomaly in newborn is, yes, it's Epstein anomaly. My purpose is not to ask you about this lithium leads to Epstein, but my purpose to give you the concept what other problem occur in mother during pregnancy leads to classical defect in the fetus or baby born. This comes very frequently. If mother is taking lithium, chance baby will have Epstein anomaly of heart. If mother is having SLE, complete heart block occur in the baby. Complete heart block occur in the baby. Congenital complete heart block. If mother is having mumps during pregnancy, EMF. Endomyocardial fibroelastosis. Mother is having mumps during pregnancy, baby will have endomyocardial fibroelastosis. Mother is taking carbimazole, methimazole. You know, these are the anti-thyroid medication. Aplasia cutis congenita occur in the baby. This question was asked in INI-CET, June 2020. It may come. FMGE standard increasing. Which anti-thyroid drug mother is taking? Baby develop aplasia cutis congenita. On scalp, the round portion where skin and hair is absent. That is aplasia cutis congenita. Mother is taking erythromycin. What problem occur in the baby? What problem? It's pyloric stenosis. Sodium valproate. Mother is taking sodium valproate. Neural tube defect. This was asked in last FMG. Mother taking sodium valproate. What problem occur in the baby? It's neural tube defect. I am holding. Remember this slide. Mother is taking lithium, Epstein anomaly of heart. Mother is having SLE, congenital heart block. Mother is having mumps. These all are very good quiz question also. Mother is having mumps. Endocardial fibroelastosis. Mother is taking anti-thyroid medication, aplasia cutis congenita. Mother is having SLE, complete heart block occur in the baby. Mother is taking lithium, Epstein anomaly of heart. Mother is taking erythromycin, pyloric stenosis. Mother is taking sodium valproate, neural tube defect. You will be getting question because we are in the mid of 100 top question in pediatrics. Answer this question. This is again 3 time in last 4 year. Very easy. 3 time in last 4 year. Full term neonate. 4 hour after birth. Respiratory distress. X-ray given suggestive of. X-ray में क्या दिख रहा है? Intestinal loop in thorax. Heart shifted towards right side. So what is this? This is congenital diaphragmatic hernia. Congenital diaphragmatic hernia. Herniation of intestine through diaphragm into thoracic cavity. Most common through foramen of Bok-Taylor. ठीक है. इंटेस्टाइन थॉरेक्स में. एब्डोमेन क्या होगा? स्केफॉइड शेप. हार्ट कहाँ शिफ्ट होगा? राइट साइड में. एपेक्स बीट towards right side. Chest. When we auscultate the chest, instead of breath sound, we heard a gurgling sound. Why? Because gut is there in thoracic cavity. So 2 days old baby, when you examine, comes to you with respiratory distress, apex on the right side, abdomen scaphoid shape, X-ray show dextro position of the heart, air fluid level in the thoracic cavity. What is this? Diaphragmatic hernia. 2 days old baby, respiratory distress, you are unable to localize the heartbeat or apex, cardiac apex, chest showing gurgling sound. What is this? Diaphragmatic hernia. X-ray show air fluid level in chest, air fluid level in chest, and dextro position of heart. Dextro position of heart. X-ray shows dextro position, heart comes to the right side. Heart comes to the right side. Dextro position of the heart. Dextro position of the heart. And air fluid level in the chest. Air fluid level in the chest. Clear? Clear? Diaphragmatic hernia, HMD, TTN. Lots of questions are there. Homocystinuria, Tay-Sachs, Gaucher, Alkaptonuria. Again, lot of question will be there. Down, Turner, Klinefelter, DeGeorge, milestone, vaccine, live vaccine, vaccine to be not to be defreeze. Yes, yes, yes. We have covered all those concepts, all those questions till now. Many more to come. So concentrate. Now answer this question. Typical ECG, peaked T wave changes seen in hyperkalemia. So hypokalemia, you have U wave. Hypercalcemia, hyper, calcium is more, right? QTC will decrease. Hypocalcemia, calcium is less, so QTC will prolong. T wave changes. Little more detail. If potassium level is more than 6, you get tall T wave. If potassium level more than 7.5, prolonged PR, broad QRS complex. Potassium level more than 9, we have syn wave. Syn wave. More than 6, tall T wave. More than 7.5, prolonged PR, broad QRS. More than 9, syn wave, syn wave, syn wave. Hyperkalemia. All are the feature of hyperkalemia except tall T wave, broad QRS, short PR, syn wave. Short PR is not a feature of hyperkalemia. Hyperkalemia feature is prolonged PR. So remember these 4 ECG changes in hyperkalemia. Remember these 4 ECG changes in hyperkalemia. QTC, I told you, if calcium increase, QTC down. If calcium down, QTC increase. Corrected QT interval. Just remember in your mind in the end time when you are going for exam. Classical history based question, prototype, easiest question, comes at least 5-6 times in NEET-PG, once in FMG. It's very easy. You need to read this question properly. Very easy. 2 weeks after a viral syndrome, 2-year-old child develops bruising, generalized petechiae, more prominent over legs. No hepatosplenomegaly, no lymphadenopathy, examination normal, lab study shows normal hemoglobin, hematocrit, WBC, but platelet count is 20,000. Thrombocytopenia. After a viral infection, antibody forms which connect to platelet GP2B3A. GP2B3A. Antibody coated platelet destroyed in spleen. Antibody coated platelet destroyed in spleen. This is ITP, where no abnormality is there, no hepatosplenomegaly, no lymphadenopathy, nothing. Everything is normal. Physical examination is normal, but child platelets are low. ITP. It is a classical history of viral infection. Don't afraid with long history based question. It is the easiest question. Easiest question. After a viral, child develop petechial hemorrhages, more prominent over leg, no hepatomegaly, no lymphadenopathy, and only platelet is low. It is idiopathic thrombocytopenic purpura. My friend, when you work in a pediatrics in the first year, you will see 50-60 cases of ITP in a year. बहुत सबसे common platelet disorder ITP. Clear? Little tough, but try. 15-year-old female present with history of dyspnea on exertion. She find wide and fixed splitting of second heart sound. Stuck here. Wide and fixed splitting of second heart sound. Something come here. Second heart sound, wide and fixed splitting. Two possibilities are there. Look, child is cyanosed. Yes, only one answer in this universe. Second heart sound, wide and fixed split, child is cyanosed. It is TAPVC, total anomalous pulmonary venous connection. Second heart sound, wide and fixed split, cyanosis is not there. Then child is having ASD. Child is having ASD. ECG shows left axis deviation, then it is ostium primum ASD. ECG show right axis deviation, then ostium secundum ASD. Come to the question again. Second heart sound wide and fixed split. Murmur is there. Okay. But second heart sound wide and fixed split. ECG show left axis deviation. The most possible diagnosis is ostium primum ASD. If ECG show right axis deviation, then ostium secundum ASD. ECG show left axis deviation, then it is ostium primum ASD. Am I clear? Am I clear? 15-year-old, history of dyspnea, second heart sound wide and fixed split. Then it is ASD. No cyanosis, ASD. Concentrate on ECG. ECG show left axis deviation, ostium primum ASD. ECG show right axis deviation, ostium secundum ASD. So simple, na? So simple. The classical question makes so easy. Second heart sound wide and fixed split. Look for cyanosis. There, TAPVC. Question end. No cyanosis. Then it's ASD. Look at ECG. Left axis, ostium primum. Right axis, ostium secundum. Again, one more classical question on CHD. See. Newborn, that is cyanotic. Congenital heart disease. Increase left ventricular impulse. 3/6 murmur. Oligemic lung field. Oligemic lung field means see, try to understand the concept. Cyanotic CHD. Increase pulmonary blood flow, decrease pulmonary blood flow. How can we say increase pulmonary blood flow? हिस्ट्री से और चेस्ट एक्सरे से. चेस्ट एक्सरे प्लेथोरिक है और हिस्ट्री हमें क्या मिल रही है? बार बार बच्चे को खांसी जुकाम होता है. पल्मोनरी ब्लड फ्लो इंक्रीज. डिक्रीज पल्मोनरी ब्लड फ्लो अगेन हिस्ट्री से, हिस्ट्री ऑफ साइनोटिक स्पेल. बच्चा रोने पर और नीला हो जाता है, रोने पर और नीला हो जाता है. और ओलिगेमिक लंग फील्ड्स. सबसे पहले हमें ये डिसाइड करना है कि वी आर डीलिंग विद इंक्रीज फ्लो और डिक्रीज फ्लो. आते हैं क्वेश्चन पे फिर. एक्सरे शोज ओलिगेमिक लंग फील्ड मींस वी आर डीलिंग विद decreased pulmonary blood flow. Two possibilities are there grossly. Either it's TOF or it's tricuspid atresia. TOF और tricuspid atresia. TOF RV फोर्सेस होंगे, ECG में राइट एक्सिस डेविएशन होगा. ट्राइकस्पिड अट्रेजिया LV फोर्स होगा और ECG में लेफ्ट एक्सिस डेविएशन होगा. आते हैं अभी क्वेश्चन पे. ECG शो लेफ्ट एक्सिस डेविएशन, इंक्रीज लेफ्ट वेंट्रिकुलर इंपल्स, ओलिगेमिक लंग फील्ड, लेफ्ट वेंट्रिकुलर डोमिनेंस. क्या हो गया ये? व्हाट इज दिस? ट्राइकस्पिड अट्रेजिया. होता क्या है देखो. Normally, impure blood from SVC come to RA, then to RV, then into PA. Pure blood from LA, LV to the body. But here, tricuspid wall is atretic, block. So all impure blood goes to LA and then goes to body. Okay. So when tricuspid wall is atretic, RV is not developing. So RV is hypoplastic. So main ventricle is LV. LV apex. Left axis deviation. Cyanotic child, decreased pulmonary blood flow, polyichemic lung field, LV apex, LV dominance, left axis deviation. It is tricuspid atresia. Simple. CHD is simple if we know the concept very well. It's tricuspid atresia. It's tricuspid atresia. Am I clear? Am I clear? It's tricuspid atresia. See the question. Cyanotic, congenital heart disease, increased left ventricular impulse. X-ray shows oligemic. ECG show left axis deviation, left ventricular dominance. The most likely diagnosis is tricuspid atresia. Clear? Clear? This is again a classical question with classical concept coming almost alternate year. Alternate year. 10-year-old boy presented with gross hematuria, significant dysmorphic RBC 2 days after attack of URI. Means upper respiratory infection. Then RBC in urine. RBC in urine means glomerulonephritis preceded by upper respiratory infection. So what are the possibilities? So key points क्या है? After URI के कितने दिन बाद RBC यूरिन में आई? 2 दिन या 2 वीक? अगर 2 दिन में आई है तो ये हो गया IgA नेफ्रोपैथी, और 2 वीक में आई है तो ये हो गया पोस्ट स्ट्रेप्टोकोकल ग्लोमेरुलोनेफ्राइटिस. क्वेश्चन में देखिए, 10-year-old बॉय प्रेजेंटेड विथ ग्रॉस हिमेचूरिया, यूरिन में आरबीसी आ गई, सिग्निफिकेंट आरबीसी 2 days आफ्टर द अटैक ऑफ यूआरआई. 2 days, 2 दिन पहले यूआरआई हुआ था, आज यूरिन में आरबीसी आ गई, तो ये क्या है? IgA नेफ्रोपैथी. यूआरआई हुआ था 2 वीक के बाद यूरिन में आरबीसी आई, वो क्या है? पोस्ट स्ट्रेप्टोकोकल ग्लोमेरुलोनेफ्राइटिस. पोस्ट स्ट्रेप्टोकोकल ग्लोमेरुलोनेफ्राइटिस. तो इसका आंसर क्या हो गया? IgA नेफ्रोपैथी. FMG लास्ट ईयर, लास्ट टू लास्ट ईयर, लास्ट टू लास्ट ईयर, 21, 22, 23. Promise every year you have this question. Read this question. In one or another way, this question was there. A 7-year-old boy, sore throat, 2 week back URI. Now develop edema, urine is Coca-Cola color, blood pressure is hypertensive, serum complement is low. What is this? Post streptococcal glomerulonephritis. After throat infection, 2 week, then child develop Coca-Cola color urine, hematuria. It is post streptococcal. 2 days, IgA nephropathy. What happened in post streptococcal glomerulonephritis? Characterized by gross hematuria, edema, hypertension, decreased urine output. It is caused by group A beta hemolytic streptococci, which occur after throat as well as in skin infection. Throat strains are 4 and 12, skin strain are 49. Throat infection common during winter, incubation period is 2 weeks. Skin infection common during summer, incubation period 6 to 8 weeks. Post streptococcal glomerulonephritis, this is the classical history. 2 weeks after throat infection, 2 days after throat infection, IgA nephropathy. Answer. Which of the following statement is true regarding post-streptococcal glomerulonephritis? Serum complement level is normal. Absolutely wrong. Serum complement is decreased. Lifelong penicillin prophylaxis is indicated. No, because there are few strain. Once infection, lifelong immunity. Rheumatic fever also caused by group A beta hemolytic streptococci. There we give very long prophylaxis. Here, no need for any prophylaxis. 10% children develop chronic glomerulonephritis. No, it is less than 1%. Prognosis is very good. So B is not right. C is not right. D is not right. Hypertensive encephalopathy is a recognized complication. Yes, sometime child present in emergency with encephalopathy. You took the BP comes 200 by 120. Then you investigate, urine shows RBC. Then it turned out to be post-streptococcal glomerulonephritis. Yes, yes, yes. Hypertensive encephalopathy is a recognized complication. A is right. A is right. Answer. Answer this question. 4-year-old boy present with puffiness of eyes, pedal edema, lab study revealed massive proteinuria. Diagnosis of nephrotic syndrome was made. So it's nephrotic syndrome. So many questions on these concepts. That's why I choose these questions. Following statement regarding is correct. So nephrotic syndrome characterized by number 1, massive protein urea. What is the definition of massive protein urea? More than 1 gram per body surface area meter square per day. When protein is losing so much, there is hypoalbuminemia. Number 3, there is edema. Number 4, there is hyperlipidemia. And number 5, there is hypercoagulability. Most common cause of nephrotic syndrome in children is minimal change disease, and they have responsive to steroid with very good prognosis. Keeping all these words in mind, come to the question. Most commonly caused by minimal change disease in childhood? Yes, correct. Usually result in end stage renal disease by 10 years? No. Nephrotic syndrome prognosis is very good. Characterized by normal serum lipid and cholesterol. Normal? No. Hyperlipidemia. It is characterized by hyperlipidemia. Normal, not. Poor response to steroid? No, it is good response to steroid. 95% nephrotic syndrome is minimal change disease, and they are very good responder to steroid. So B, C and D is wrong. A is right. Nephrotic syndrome most commonly caused by minimal change disease in childhood. Answer. If a child comes with puffiness of eyes and you are suspecting nephrotic syndrome, the definition wise, we need to give a container to the child, tell the child to collect the urine in it for 24 hours. Then we calculate the protein. It should be more than 1 gram per body surface area meter square per day. More than 1000 milligram body surface area meter square per 24 hours, or 1000 divided by 24 body surface area meter square per hour. So it will come more than 40 milligram body surface area meter square per hour. If we calculate on the basis of per hour, it should be more than 40 milligram. If per day, it should be more than 1 gram. So this was asked. So it is 40 milligram body surface area meter square per hour. Nephrotic range proteinuria, more than 1 gram body surface area meter square per day, or more than 40 milligram body surface area per meter square per hour. Simplest traditional question. Serum iron low 15. Normal value is 50 to 150. And TIBC increase. Normal value is 300 to 350. Serum iron low, TIBC increase, only one condition, that is iron deficiency anemia. I am not going in detail. Just remember one thing, serum iron low, TIBC increase, iron deficiency anemia. Iron deficiency anemia. Very good question. Previous 4 paper, every paper of FMG have this question. Believe me, trust me. 4-week old male infant, 2-week history of intermittent vomiting, weight loss of 300 gram, serum electrolyte sodium 147, potassium 2.9, bicarb 32, chloride 89. Vomiting with bicarb 32, normal is 22 to 24. So it is alkalosis. Chloride normally 100, it's 89. So what is there? Hypochloremic metabolic alkalosis. With history of vomiting in a 4-week-old baby, it's denote hypertrophic pyloric stenosis. What happened? This is HCl secrete here. HCl goes out. H ion goes out, alkalosis. Chloride ion goes out, hypochloremic. So, hypochloremic metabolic alkalosis. Clear? Now, 2-3 points you need to remember. It is more common in first born male child. You get history of erythromycin taken by mother during pregnancy. Clinical feature, projectile non-bilious vomiting. Projectile, forceful. Have you seen any baby with pyloric stenosis vomiting projectile fall away from the body, and it's non-bilious? Non-bilious. Classical, you can pick the question by any way. Male child, projectile non-bilious vomiting, lab study revealed hypochloremia metabolic alkalosis. Now, examination. Two things are there. peristaltic wave and lump. Peristaltic wave move from left to right, lump present in epigastrium. Peristaltic wave seen best after feeding. Lump best palpate after vomiting. When child vomit, musculature is relaxed, then you better palpate the lump. Peristaltic wave, when child feed properly and then milk passes through stenotic segment, then you find peristaltic wave. This is the MCQ. Movement of peristaltic wave from left to right. And best seen, peristaltic wave best seen after feeding, and lump best palpate after vomiting, This is string sign, or some book says mushroom sign. Some book says mushroom sign. You can see na, distended stomach, and this is the narrow segment of pyloric stenosis. String sign or mushroom sign. Investigation of choice is not barium. It's not barium. Investigation of choice, abdominal USG. You may find 3-4 question in last 4 FMGE exam. Trust me, go and check. And you are able to solve all with this much knowledge. Pyloric stenosis. Strength of glucose in hypoosmolar ORS. You are going for exam and you should know about ORS. Sodium, potassium, chloride, citrate, glucose, osmolarity. These things are difficult, but you have to remember, no other way. Sodium 75, glucose is also 75. Potassium 20, chloride 65, citrate 10, osmolarity 245. They can ask you anything. What is the osmolarity of hyposmolar ORS? 245. What is the strength of sodium? 75. What is the strength of glucose? 75. So best thing, just do and remember. Remember, hyposmolar ORS. This is the way of a class, na? I will speak, you listen. Then I will again speak, you listen, and you are able to memorize it. Sodium 75, same is glucose 75. Potassium 20, citrate 10, chloride 10 कम होता है सोडियम से, यानी 65. Osmolarity 245. Osmolarity 245. Clear? Clear? Strength of glucose in hyposmolar ORS 75. Child weighing 8 kg, presented with loose motion. On assessment, sign of some dehydration is there. When we say child is having no dehydration, some dehydration, or severe dehydration, no, some, or severe. When we say, now, child comes with loose stool since 2-3 days. When we examine the child, child is irritable and child is thirsty. Irritable and thirsty, it indicates child is having some dehydration. When you examine the child, you are sitting in the night emergency, a child comes, 2-year-old child, Mother is telling child is passing loose motion since last 3 days, 20, 15 motion in a day. And when you examine, child is lethargic, totally dull, not able to drink. This is severe dehydration. So these 2 points are the key. Whenever we diagnose, these 2 points are the key. Rest all will help. Rest all will help. But these are not the key. Means eyeball shrunken, some markedly shrunken, severe. Skin turgor decrease, markedly decrease, severe. Oral mucosa dry, markedly dry, severe. Those are help, but these two are classical. Child is irritable and thirsty, some dehydration. Lethargic, not able to drink, severe dehydration. When you find this examiner is kind enough, they already given you some dehydration. Else, examiner will give you child is irritable, thirsty, what is the treatment? Irritable and thirsty means some dehydration. But examiner is kind enough, he directly write to you some dehydration. So whenever some dehydration, we use the plan B. What is plan B? What is plan B in the treatment of dehydration? Plan B. Weight into 75 ml ORS in 4 hours. What is the weight? 8 kg. 8 into 75 ml ORS. Answer would be 600 ml ORS. First thing, we need to find out whether dehydration is some or severe. Dehydration is some or severe. Examiner is kind enough, he directly mentioned this dehydration is some. So some dehydration, we use plan B. What is the weight of the child? Multiplied by 75 ml ORS. So it is 600 ml ORS given in first 4 hours. Remember, you are going for exam, diarrhea, PM, marasmus, kwashiorkor, Down syndrome, Turner syndrome, Alkaptonuria, Tay-Sachs, Homocystinuria. Basic about vaccination, basic about developmental milestone, basic CHD, iron deficiency anemia. These are the important topics. Glomerulonephritis, nephrotic syndrome. Papers are full of these questions. That's why we are here. 100 top question in pediatrics on Medway by me, Dr. Sanjay Khatri. Hope you are liking the class. Again, I told you ITP question is the landmark question. Very big question. So many times is there. Another is this. Read this properly. Try to make an answer. Read this question properly. Try to make an answer. "12 days after upper respiratory infection, a 12-year boy complained of weakness in lower extremities. Several days, weakness progressed to include trunk, means ascending paralysis. Weakness as described and no deep tendon reflexes, means hypotonia. 12 days after upper respiratory infection. So it is acute, ascending, symmetrical, flaccid paralysis. Each and every word is very important. It's acute, short history, 12 days. Ascending, first lower limb involved, then trunk and upper limb involved. Symmetrical, when you examine, both side weakness is same. Flaccid, deep tendon reflex absent, paralysis. If you write this word, acute ascending symmetrical flaccid paralysis, it has to be Guillain-Barre syndrome. It has to be Guillain-Barre syndrome. Ask two questions from the mother. Whether child is having loose motion 2 weeks before, or child is having respiratory infection 2 weeks before. If it occur after loose motion, then it has to be Campylobacter jejuni. If respiratory infection, Mycoplasma pneumoniae or H. influenzae. Got it? If it occur after loose motion, Campylobacter jejuni. If it occur after respiratory infection, Mycoplasma pneumoniae. You get a history. Okay, it's acute ascending symmetrical flaccid paralysis. How we diagnose? We do a lumbar puncture. Lumbar puncture will show cells normal, only protein increase. What word we use for this? Albuminocytological dissociation. Albuminocytological dissociation. Cells normal, but protein increase. It's diagnostic of Guillain-Barre syndrome. Albuminocytological dissociation. Whenever meningitis occur, cell increase, then protein increase. But what happen in Guillain-Barre syndrome? Albuminocytological dissociation. Cell normal, protein increase. Cell normal, protein increase. This is classical Guillain-Barre syndrome. Guillain-Barre syndrome, acute ascending symmetrical flaccid paralysis. Occur after loose motion, Campylobacter jejuni. Occur after respiratory infection, Mycoplasma pneumoniae and H. influenzae. Clear? Very good question. Read carefully. Then I will explain you. Six-month-old present with failure to thrive, eczema, infection and thrombocytopenia. This is the triad. Tie. T for thrombocytopenia. I for infection. E for eczema. Triad, and this is Wiskott-Aldrich syndrome. Wiskott-Aldrich syndrome is a triad of tie, thrombocytopenia, infection, eczema. One more thing, Wiskott-Aldrich syndrome, PBF shows tiny platelets, microthrombocytes, tiny platelets. Tiny platelets, triad of tie. It is Wiskott-Aldrich syndrome. It is X-linked recessive disorder. So only males are affected, females are carrier. That's why male present with failure to thrive, eczema, infection, low platelet and tiny platelet. It is Wiskott-Aldrich syndrome. It is Wiskott-Aldrich syndrome. Very good practical question. Can you answer this? earliest response to iron therapy in iron deficiency anemia. You have a child, hemoglobin of 6. You investigate and it turned out to be iron deficiency anemia. Low iron, increase TIBC. So iron deficiency anemia and you start iron. MCQ, what is the earliest response occur in body when you start iron in iron deficiency anemia? If you know, you can answer, else you may turn out to be put it wrong. Anybody in the comment box, what is the answer for this question? What is the answer for this question? Anybody? Now see. Once we start iron, earliest response 12 to 24 hour increase in iron containing enzyme, replacement of iron containing enzymes. What are the iron containing enzymes? Catalase, peroxidase, MAO. Initially their level increase from 24 to 36 hour. Erythroid hyperplasia. 48 to 72 hours. Reticulocytosis. 4 to 30th day. Increase in hemoglobin. 1 to 3 month. Replacement of stores. Replacement of stores. So first change क्या होता है? Replacement of intracellular enzymes, iron containing enzymes, which leads to subjective improvement, mood elevate, appetite increase, distraction comes, concentration increase. Yes, because MAO is iron containing enzymes. When you start iron, सबसे पहले MAO का लेवल नॉर्मल होता है. माओ इनिबिटर्स फार्मा में पढ़ते हैं ना. जैसे इनका लेवल नॉर्मल होता है, एपेटाइट इंक्रीज होती है, कंसंट्रेशन इंक्रीज होती है, मूड स्टेबल होता है. दीज आर द अर्लीस्ट चेंज. ओपीडी में पेरेंट्स आते हैं, बच्चे को भूख नहीं लगती. बीइंग ए पीडियाट्रिशियन हम सबसे पहले क्या करते हैं? आयरन शुरू कर देते हैं. सब्जेक्टिव इंप्रूवमेंट, इंक्रीज एपेटाइट. Reticulocytosis occur 3rd day. Hemoglobin begin to increase 4th day. Earliest response, replacement of intracellular iron enzyme. If this is not given, then write subjective improvement, increase appetite, increase concentration, increase mood. Got my point? Response to iron therapy in iron deficiency anemia. Answer this question. I will explain you this question and this question. Please give me 1 minute. If a child comes with muscle or joint bleed, we are suspecting problem in clotting factor pathway. And what we will do? We will do PT and APTT. Suppose PT is prolonged, then we are dealing with 7-factor deficiency. If APTT is prolonged, then we are dealing with 8, 9, 11, 12-factor deficiency. A-factor deficiency, hemophilia A. 9-factor deficiency, hemophilia B. 11-factor deficiency, hemophilia C. If we have prolonged PT and APTT both, we are dealing with either 2, 5 or 10-factor deficiency. PT and APTT slightly prolonged, but main culprit is TT. Thrombin time is prolonged. Then it's defect of fibrinogen, either afibrogeninemia or dysfibrogeninemia. All are prolonged, all deranged. PT, APTT, TT, bleeding time, clotting time, sub all are deranged. All are deranged. Then it is DIC. Now listen carefully. Listen carefully. All normal. Still bleeding. All normal. PT normal, TT normal, APTT normal, platelet normal, subnormal. Still bleed. Then it has to be 13 factor deficiency, which is diagnosed by urea clot lysis test. Urea clot lysis test, which is diagnosed by urea clot lysis test. It's simple, my friend, it's simple. See the question, you will be clear in the concept. Read the question carefully. Read the question carefully. Profuse bleeding due to fall on the road. Joint में bleeding हो रही है उसके. Bleeding not stopped easily. Child rushed to the hospital where lab study shows normal platelets. PT and APTT slightly high associated with high TT. Here is the answer. TT high. So what is the answer? It's a fibrinogen defect. Afibrogeninemia. Afibrogeninemia. Fibrinogen defect. High TT. Fibrinogen defect. 15-year massive bleeding 36 hours after large cyst removed. Bleeding continue. All measure to control bleeding was unsuccessful. Bleeding continue. PT, APTT, TT, platelet count, all are normal. But bleed continue. All are normal. Simple, na? What is this? What is this? Factor 13th deficiency. Diagnosed by urea clot lysis test. Simple, my friend. First, I teach you, then I will do the application based question. You want it written in a proper way? Here is for you. If PT is increased, factor 7th deficiency. APTT is increased, 8th, 9th, 11th, 12th deficiency. Both are prolonged, 2 into 5 is equal to 10, 2, 5, 10 deficiency. Main culprit is TT, afibrogeninemia, dysfibrogeninemia. All are prolonged, it's DIC. All are normal, bleed continue, factor 13th deficiency, diagnosed by urea clot lysis test. Now, what are you feeling? Am I clear? Approach to coagulation disorder. These are the two classical and toughest questions which you are easily able to do. TT is prolonged, afibrogeninemia. All normal, bleeding continue, factor 13th defect, diagnosed by urea clot lysis test. Clear? Clear? Answer this question. After COVID, questions from respiratory suddenly increase in the exam, and this is one of those questions. Read carefully, then we will proceed further. Developed noisy breathing on inspiration. Noisy breathing मतलब stridor है. Marked retraction of chest wall, flaring of nostril, barking cough. Upper respiratory 2 days back. Treatment. What is this? This condition is known as croup. Croup. Acute LTB. Acute laryngotracheal bronchitis caused by para-influenza virus. There is a classical history of URI 2 to 3 days back. 2 to 3 days से पेशेंट को URI है, रनिंग नोज कफ माइल्ड फीवर, रनिंग नोज कफ माइल्ड फीवर. Then child develops signs of respiratory obstruction in the form of stridor, barking cough, and respiratory retractions. Child को 2-3 दिन से URI है, then suddenly ये साउंड आने लगी. स्ट्राइडर, बार्किंग कफ, रेस्पिरेटरी रिट्रैक्शन. 2-3 दिन से URI था, अभी ये सिम्टम शुरू हुए हैं. एक्यूट LTB, ये देखो, acute laryngotracheal bronchitis, voice change, larynx involved, barking cough, larynx involved, inspiratory stridor, trachea involved, increased breathing, bronchitis, acute laryngotracheal bronchitis, larynx, trachea and bronchials, everything involved. Acute LTB, croup. एक्सरे में कैसे डायग्नोस करेंगे? स्टिपल साइन दिख रहा है, ये नैरो स्टिपल साइन. स्टिपल क्या होता है? चर्च की टॉप को हम स्टिपल बोलते हैं. लास्ट ईयर एक्सरे शोज स्टिपल साइन. व्हाट इज द कंडीशन? क्रूप. acute LTB croup. History of URI for 2 to 3 days, then signs of respiratory obstruction develop. This is acute laryngotracheal bronchitis. Acute laryngotracheal bronchitis. Treatment. Nebulization with epinephrine plus oral steroid. Clear? URI 2-3 days, then signs of acute laryngotracheal bronchitis develop. Hoarseness of voice, stridor, barking cough. Stipple sign on X-ray. Treatment with nebulization with epinephrine and oral steroid. This is the classical question on croup. Noisy breathing, marked retraction, barking cough, URI for 2 days. Which of the following therapies indicated? Inhaled epinephrine plus dose of steroid. Clear? Croup is clear, so simple. अब आते हैं एपिग्लोटाइटिस पे. Epiglottitis. It is acute fulminant condition. Epiglottitis is acute fulminant condition. It's acute fulminant condition. Child caused by H. influenzae and Streptococcus pneumoniae. Symptoms start with fever and throat pain, or you can say throat pain. Rapidly progress within 6 hours, progress to toxic look, dysphagia, drooling of saliva. Within 6 hours, can you imagine? बच्चे को छोड़ के गए हैं पेरेंट्स सुबह 10 बजे केयर टेकर के साथ, थोड़ा सा फीवर है, थ्रोट पेन है, 4 बजे उनके पास फोन आता है, बच्चा इमरजेंसी में इंटूबेट होके एडमिट हो गया. Such a progressive course, acute fulminating condition. Bend forward, tripod sign, हाथ ऐसे, neck extend, air hunger, because उसको extend रखना पड़ता है air hunger के लिए. Drooling and toxic child, drooling of saliva and toxic look. This is epiglottitis, rapid fulminating course. Diagnose. How can we diagnose? If child reach to us 6-7 hours after, the only way, do the laryngoscopy. Direct visualization of epiglottitis. If you examine, this is normal. This is epiglottis, no? Normal. This is epiglottitis, cherry red. Now see, larynx is there. If epiglottis is swollen, you are not able to see the airway. Where you can see the airway. So child comes with toxic look, drooling of saliva, respiratory, air hunger in emergency. So without reaching to diagnosis, you first aim, I will intubate the child. As soon as you open the laryngoscope, you see the epiglottis, cherry red swollen. Diagnosis in front of you. Diagnosis is front of you. This is epiglottitis. Epiglottitis. If child comes to you 3-4 hours after the sore throat and fever, you get a time, child is not sick, do a x-ray, lateral neck x-ray, and you will get a thumb sign. Thumb sign. Thumb sign. Steeple sign in croup. Thumb sign in epiglottitis. Thumb sign in epiglottitis. Now see, treatment. The first step of treatment, establish the airway. Number 2, start antibiotic. Number 3, no role of steroid or epinephrine. Because it is caused by Streptococcus pneumoniae or H. influenzae, you can start higher antibiotic, meropenem, ceftriaxone. The first thing, establish the airway. As time pass, you are not able to intubate the child. So first quickly intubate the child, make airway secure, then start antibiotic. In good center of word, mortality with epiglottitis is 10 to 15%. You need to act very quickly. You are expert in intubation because it's a difficult intubation. First, establish the airway and start antibiotics. Now, read this question. I will read for you. 6-year-old, fully immunized boy brought to the emergency room within 3-hour history of fever. 3-hour history of fever. Sore throat. Child appear alert, anxious, toxic. Inspiratory stridor, drooling. Sitting on examination table, leaning forward, neck extended, lateral radiograph shown, thumb sign is there. So what is the condition? Epiglottitis. So examiner want, what is the immediate management? Culture? No. IV line? No. Nebulization? No. Establish the airway. First thing to establish the airway, if we poke the child, put the IV line, take the culture, nebulize, it will deteriorate the child. So croup treatment is epinephrine nebulization, oral steroid. Epiglottitis, establish the airway. If this is not given in the choice, high antibiotic. Epiglottitis and croup. Remember, post-COVID, weightage of respiratory topics increase in the exam. Your last FNB exam, clear question. Child with URI developed stridor, X-ray show steeple sign, croup. X-ray show thumb and thumb appearance. It is epiglottitis. These are simple. You just listen, read the question, sincerely think about it. You can do these questions. Answer this question. Child with crampy abdominal pain, rash over buttocks. This is classical rash of HSP, Hinoch-Scollin purpura, which is characterized by rash, arthritis, abdominal pain, and glomerulonephritis. Rash is the hallmark present in 100% of the patient. In our patient, rash is there, abdominal pain is there, microscopic hematuria, glomerulonephritis is there. This is Hinoch-Scollin purpura. Remember this picture, this rash, these four features: rash, arthritis, abdominal pain, glomerulonephritis. It is Hinoch-Scollin purpura. It is Hinoch-Scollin purpura. This is again a very good question. The most appropriate method to obtain urine specimen for culture in a 9-month-old girl. Definition of UTI based on urine culture sensitivity. This is the way we define UTI. So, if we take sample from mid-stream urine, child is passing the urine, tell the mother, take the container in front of a stream and collect 10 ml of urine. So when we make the diagnosis of UTI, colony forming unit should be more than 10 to the power 5 per ml. If we collect urine by catheterization, then it is 5 into 10 to the power 4. If urine contain 10 to the power 3, it's not UTI. It should be more than 10 to the power 5. If midstream urine, if you collect urine from catheterization, it should be more than 5 into 10 to the power 4. But if you collect urine from suprapubic aspiration, make the child lie on the table, take the syringe, feel the pubic symphysis, put the syringe down, piston up, urine will come in the syringe. A single colony forming unit is diagnostic of UTI. So that's why 9-month-old girl, which is the best method to collect urine, it is suprapubic aspiration. Mind, 9 months. You can't take suprapubic puncture in 5-year-old child. He can pass urine and give you for collection. He will never allow you to poke the syringe and take suprapubic. It's appropriate for 6 months to 12 months. We can hold the child properly, take suprapubic sample for urine culture. So this asked 2 times. Which is the best method? Suprapubic aspiration for a 9-month-old girl. Read this question. Four-year-old boy present in emergency. Mother complain marked pallor, decreased urine output, multiple petechial spots all over body. Hematocrit 28%, means 1/3 kar do hemoglobin 9, platelet 30,000, 100, create 4.5. History of bloody diarrhea 3 days back. What is this condition? I will explain you. This is hemolytic uremic syndrome. hemolytic uremic syndrome. It's a triad of microangiopathic hemolytic anemia, thrombocytopenia, acute renal failure. ATM. ATM. We are all familiar with this word. ATM. Acute renal failure, thrombocytopenia, microangiopathic hemolytic anemia. So how this happen? There is an attack of dysentery, either E. coli or Shigella. In India, Shigella is more common. They liberate a toxin. In case of E. coli, known as virotoxin. In case of Shigella, known as Shiga toxin. Normally, what happen? WBC and RBC and platelet passes through renal vascular endothelium, but this toxin damage this endothelium. This endothelium get damaged. Now RBC and platelet pass through this endothelium, they get trapped, leads to anemia, thrombocytopenia, and renal endothelium blocked, patient goes into ARF. So see, classical history, complain of pallor, anemia, decreased urine output, multiple petechial spots, thrombocytopenia, platelets 30,000, hemoglobin 9, 100 create 4.5, ARF, thrombocytopenia, anemia, bloody diarrhea 3 days back. इससे और क्या चाहिए दोस्त? Dysentery followed by ATM. This is hemolytic uremic syndrome. This is hemolytic uremic syndrome. Hemolytic uremic syndrome, HUS. That was HSP, Hinox choline purpura. This is hemolytic uremic syndrome. Yes, 2-month-old baby with central cyanosis presented with following finding on X-ray and ECG. Cyanotic. X-ray, classical finding in X-ray is box-shaped heart. And ECG, can you appreciate? Tall P wave. P is equal to QRS, tall P wave, also known as Himalayan P wave. Tall P wave, Himalayan P wave on ECG. X-ray shows box-shaped heart. It is Epstein anomaly. It is Epstein anomaly. Am I clear? Am I clear? This is Epstein anomaly. Now, these are the classical X-ray in CHD. So this what you are expecting. This is box-shaped heart. This is agon side. This is snowman or figure of 8. And this is boot-shaped heart. Box, egg, snowman, boot. This is Epstein. This is TGA. This is TAPVC. 2 time in 4 year. X-ray of TAPVC. Snowman or figure of 8. This is off. Just watch this X-ray again and again. Just X-ray in CHD. Box shaped in Epstein. egg on site in TGA, snowman or figure of 8 in TAPVC, boot shaped heart in TOF, Epstein, TGA, TAPVC, TOF. Clear? You will not forget these X-ray. And this question, tall P wave, Himalayan P wave in Epstein, box shaped heart, Epstein, cyanotic child with this X-ray and ECG, it is Epstein anomaly. It is Epstein anomaly. Answer this question. Ten-year-old girl admitted with complaint of prolonged low-grade fever, headache, vomiting, convulsion. Fever with convulsion, 10-year-old. It can be meningitis. Which meningitis? Tubercular, bacterial, fungal, viral, aseptic. Answer will come only from CSF examination. Answer will come only from CSF examination, lumbar puncture. So when we did a lumbar puncture, now these are the interpretation. If we find less than 5 cell and all are lymphocytes, protein 20 to 40 milligram %, CSF glucose 2/3 of blood sugar. अगर blood sugar 100 है, CSF glucose 66. Protein 20 to 40, cells less than 5, all lymphocytes. This is normal finding. This is normal finding. Now, second scenario. We did a lumbar puncture and we find cells are 10 to 10,000, but mainly neutrophils. Proteins increase. Sugar markedly low, less than 1/3 of blood sugar. अगर blood sugar 100 है, CSF sugar 33 से भी कम. Cells neutrophils है, sugar markedly low है और protein increase है. ये क्या है? Pyomeningitis. This is pyomeningitis. Third scenario. We did a lumbar puncture and we find cells to 10 से 10,000 है, but all are lymphocytes. Proteins normal. Glucose normal. Cell lymphocytes हैं पर biochemistry normal है. What is this? Viral or aseptic meningitis. Fifth scenario. Cells lymphocytes है पर प्रोटीन इंक्रीज है. और शुगर 50% ऑफ ब्लड शुगर. CSF शुगर 100 है, सॉरी ब्लड शुगर 100 है, CSF शुगर 50 है. तो ये क्या है? ट्यूबरकुलर मेनिंजाइटिस. मींस टू से अगर आपको लंबा पंचर में सेल्स दिख रही है न्यूट्रोफिल और CSF ग्लूकोज मार्केडली लो है, तो ये क्या हो गया? पायोमेनिंजाइटिस. सेल्स दिख रही हैं लिम्फोसाइट्स और बायोकेमिस्ट्री नॉर्मल है, तो ये क्या हो गया? वायरल. सेल लिम्फोसाइट्स दिख रही हैं, बायोकेमिस्ट्री अल्टर्ड मतलब प्रोटीन इंक्रीज, शुगर लो, तो ये क्या हो गया? दिस इज ट्यूबरकुलर. सो क्वेश्चन पे आते हैं हमारे. prolonged fever, headache, vomiting, convulsion. CRS, no localized sign. Fundus, papilledema. CSF examination, protein 200 means protein तो increase है. Sugar 40 है, मतलब शुगर डिक्रीज है, मार्केटली डिक्रीज नहीं है. सेल काउंट 100 है और सेल्स कौन से हैं? लिम्फोसाइट्स. Lymphocytes with protein increase and CSF sugar decrease. What is this? Tubercular meningitis. Tubercular meningitis. When you do the MD or DNB, you see lot of patients like this. Yes, in our MD, we do lot of lumbar punctures. So what is this? Our madam teaches us, take the lumbar puncture fluid in 2 test tubes. One test tube we sent to the lab for interpretation. Which is the cell, what is the biochemistry, we send to the lab. Second test tube we keep by the side of patient. Our ma'am will see that test tube in the morning. What we see sometime, something hanging in the test tube. This is known as cobweb. Cobweb. And this is classical of tubercular meningitis. So this, why I spent time on this. NEET-PG and FMGE last 2 year question is on this. Medicine or pediatrics, interpretation of lumbar puncture finding. Cobweb, suggestive of tubercular meningitis. Interpretation of lumbar puncture finding. Cobweb in tubercular meningitis. So question is there on this topic. How you interpreted lumbar puncture finding. All lymphocytes less than 5, protein 20 से 40, sugar 2/3 of blood sugar, normal. Neutrophil increase, protein increase, sugar markedly low, pyomeningitis. Cells lymphocytes, biochemistry normal, viral. Cell lymphocytes, biochemistry altered. Altered means protein increase, sugar low, then it will be tubercular. Now you can understand better what is albuminocytological dissociation. Cells normal, protein increase. Present in Guillain-Barre syndrome. Albuminocytological dissociation. Albuminocytological dissociation. Answer this question. Answer this question. During a regular checkup, 8-year-old child noted a normal first heart sound, soft second heart sound, constant ejection click. Ejection click. Normal aortic wall open, no sound. Pulmonary wall open, no sound. When those walls are stenosed, opening produces sound known as ejection click. Ejection click can be constant or can be phasic. Constant ejection click, aortic stenosis. Phasic ejection click, pulmonary stenosis. Constant means tick, 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 not varies with respiration. Phasic means varies with respiration. P for P. Pulmonary click is phasic, aortic click is constant. Whereas with respiration, inspiration soft, expiration loud. Tick, tick, tick. These are the few key points. Now, keeping in this mind, click is there. So either it can be pulmonary stenosis or aortic stenosis. Now click is constant. We are moving towards aortic stenosis. Let's read the other finding also. Now see, if it is aortic stenosis, you will have constant ejection click, ejection systolic murmur on the right side, and that murmur radiating towards carotids. Constant ejection click, ejection systolic murmur on the right side, which radiating towards carotid. These findings indicate that you are dealing with aortic stenosis. If it is pulmonary stenosis, then we had a click which is phasic. Then murmur, ejection systolic murmur, which radiating towards back. But pulmonary stenosis, murmur on the left intercostal, second intercostal space. Aortic stenosis, murmur on the right intercostal space, second. Murmur radiating to carotid, aortic stenosis. Murmur radiating to back, pulmonary stenosis. Click is constant, aortic stenosis. Click is phasic, pulmonary stenosis. Come to the question. Constant ejection click favor aortic stenosis. Ejection systolic murmur over right sternal border. Right sternal border, aortic stenosis. Radiating to carotid. Again, aortic stenosis. So our answer will be aortic stenosis. Same question. Phasic ejection click. Ejection systolic murmur over left sternal border and murmur radiating towards back. Answer would be pulmonary stenosis. Answer would be pulmonary stenosis. So these are the simple. Just that examiner will check you whether you have some clinical sense. Aortic stenosis murmur radiating to carotid. Pulmonary stenosis murmur radiating to back. So this is the way we cover so many questions here. So many types of question. TAPVC, ASD. Tricuspid atresia, TOF. Pulmonary stenosis, aortic stenosis in cardiology. Metabolic disorder, Tay-Sachs disease, Gaucher's disease, Alkaptonuria, Hurler, Hunter's, Homocystinuria. Common question on vaccine, common question on milestone, GIT, PM, ORS, diarrhea, treatment, all things we have covered in this class. So, this is from Medway. Myself, Dr. Sanjay Khatri. Your pediatric educator on Medway. Yes, Medway is coming with the app for you. Try to join Mway. It is door to your dream. It's my sincere request. I put my best effort, my best experience to give best of the pediatric question to you. You hope you like the class. You revise this class again and again, and this question will help you in your exam. Okay, thank you. Bye bye. All the best to all of you. Thank you.